So, good afternoon, everybody, and welcome to the 13th Practical Pediatric Endocrine course, which is a part of our ongoing program of Advanced Pediatric Endocrine Symposium, which has been going on for the last 2 days. This program is exclusively targeted towards the pediatricians, and we are basically trying to focus mainly in terms of the various practical aspects of pediatric endocrinology, which are relevant from a pediatrician's perspective. So the topics we're going to cover today include the 3 major modules on calcium, growth, and electrolytes. And this is a part that is going to cover using case-based approaches. And these modules have been previously implemented as well in different parts of the country. So at the very offset, I'd like to make some basic introduction about what we are planning to do and how we want to proceed about that. So pediatric endocrinology is a specialty on which there have been a lot of issues in terms of awareness. And when we had come back around 15 years ago, there were issues about people not knowing and the patients not knowing what is abnormal, what is normal, how to evaluate, how to manage. So we started off with a lot of awareness programs with regards to pediatric endocrinology. I still remember this first practical pediatric endocrine program, which happened probably around over a decade ago. Professor Tripathi, Dr. Rashmi, Dr. Vikas, Dr. Mahesh, a lot of people were already there even at that program, Dr. Ayesha. And since then, we have conducted a number of programs and developed modules related to pediatric endocrinology with over 100 workshops in the country, 13 practical pediatric endocrine courses, 5 advanced courses, and 2 pediatric endocrinology for postgraduate programs. And these programs try to cover different aspects of pediatric endocrinology. But what we realized is that it's not possible to do so many physical programs in terms of resources, in terms of time. So we started developing our e-resources, starting off with a YouTube channel, which is trying to cover different aspects of pediatric endocrinology. It has got 400 videos covering entirety of both basic, advanced and super advanced aspects of pediatric endocrinology with over 1.5 million views and a large number of viewing hours which have been there in this. So this is available resource for all of you to go through. Over time, with the help of Dr. Rashmi, the entire motivating force and the Regency Hospital, we developed a lot of other things, started a fellowship program in 2017. Until now, 11 fellows, and now we have the 12th fellow, Dr. Sandeep, who has just joined us very, very recently. So this is the 12th fellow is going on, and our fellows are now different parts of the country. We started an online course, MedEClasses, which provides a very comprehensive approach in terms of evaluation and management using videos, lectures, and many other scenarios in that regards. We launched textbooks and mobile applications. Our MedEClasses or growsociety.in is a learning platform which provides validated tools for learning of pediatric endocrinology and practical assessment. All of you can go and have a look at this website. We offer courses, online courses. So we have over 100 online fellowships which are going on. And recently in this program, we had 17 people who passed off from that program. So we already have 27 people who have completed the fellowship from our side. They come here 4 times every 6 months. Visit for 3 to 5 days, see a lot of cases, a lot of online resources, and then discussions happen in that regards. Our endocrinology application is the most downloaded pediatric endocrinology app with over 5,000 installs. We have already published 3 papers and multiple are on pipeline. It provides approach based upon clinical clues, and we are developing many other models in that regards. We are coming up very soon with a personalized intelligent EMR, which will allow immediate interpretation of clinical features, suggesting diagnosis and workup. We have got multiple publications starting from the pediatric endocrinology protocols, which is in the 2nd edition. We have just released our 2nd edition of basic pediatric endocrinology targeted towards pediatricians and postgraduates. And we have got the advanced pediatric endocrinology, which is more targeted towards pediatric endocrine fellows, endocrinologists in that regard. So yesterday, Dr. Kapoor had graced the occasion to release this book, which is now available across in different platforms as well as here also at a special discount. So without wasting much time, we'll start off with the first module. But before that, I like to have a few words from our stalwarts who are there. We have got Professor V.N. Tripathi. I'll request sir to come and say a few words.
Thank you, Dr. Anurag. My colleague, Dr. Rashmi, colleague since almost 40 years, I even remember. And Vijay Jaswal is here, Vikas, and Amitesh, and of course, Anurag. And I tried, since he joined Anurag, he came back from his special training in AIMS and then Australia and all. And I tried to attend almost all initial his programs, under Grow Society. I remember 4 or 5, even when I was principal of some medical college, I used to come. And because it was just a simple but very important and simplified way, like is electrolyte, glucose, and all that. Anyway, now I have come to know that that small plant has been grown to a tree. That's, I must congratulate you all, pediatric enterology, very few people, Anurag, Vijay, Vikas, with little interest of Dr. Rashmi and me as well. And of course, these trainees, they are the delegates.
They are delegates as well as trainees.
Okay.
So many people.
Okay, from different medical colleges. Oh yes, that's very good. And I think after getting this is the second day, I think. No. Yeah.
Actually, it's the 5-day program. So
Okay. Okay. I think with the end of this this workshop, I must say, or the program or CME, you will be much wiser, particularly if you deal with the pediatric endocrinology problem. And I again congratulate the whole team in general and Anurag in particular, along with his faculty. Vikas Mehrotra from Aligarh, Dr. Vikas, Vijay, Meerut, then any other faculty?
Yeah, Dr. Mahesh is there.
Dr. Mahesh.
Bhopal.
Bhopal. Okay. Anyway, so with this, I wish all success. And as a doctor, you must be knowing, we are all learning. I did my MD in January, February 81. So still I am learning. And I try to come, and doctor must be always learning and apply. Learn, apply, relearn, apply. So with this, मैं अनुराग के लिए एक शेर से अपनी बात काम कहा, क्योंकि डॉक्टर रश्मि को मालूम है डॉक्टर त्रिपाठी एक शेर जरूर सुनाएंगे कि हम अकेले ही चले। जब ऑस्ट्रेलिया एम्स से बड़ी ट्रेनिंग लेके आए तो मुझे याद है धीरे धीरे इन्होंने कैसे किया कि हम अकेले ही चले थे जानबे मंजिल, मगर लोग आते गए, कारवां बनता गया। तो अब ये अकेले से कारवां बन गया है। यू सेड 400 वीडियोस एंड सो मेनी ये रिसर्च पेपर्स, particularly in high value journals, international. So again, so I wish that the mission, I think Anurag has started mission because I was fortunate to go. His native place in Fatehpur also. And the Dr. Rashmi must have also gone when I was Director General Medical Education. So बहुत अच्छा लगा कि एक वहां भी ये फैला रहे रोशनी को। और एक शेर के साथ आशीर्वाद के रूप में मैं अनुराग के लिए कहूंगा कि अनुराग जहां जाएंगे, चाहे ये एम्स में, चाहे ऑस्ट्रेलिया में, इवन फतेहपुर रूरल एरिया में कुछ ना कुछ लोगों के लिए करते रहते हैं, लोगों के आराम के लिए, कि अनुराग जहां जाएंगे रोशनी लुटाएंगे। केवल रीजेंसी में रोशनी नहीं लुटाते, केवल यहाँ नहीं, तो अनुराग जहां जाएंगे रोशनी लुटाएंगे। किसी चिराग का अपना मकान नहीं होता, किसी चिराग का अपना मकान नहीं होता। थैंक यू वेरी मच।
Thank you, sir. I request Dr. Vibha to give a memento of appreciation to sir. We have with us the patron of Grow Society and the chief pediatrician at Regency Hospital, Dr. Rashmi. So I'll request her to say a few words, please.
So a very good afternoon to all of you. And as every year, I see a few familiar faces this time also. However, I missed although the yesterday's program. But you all know, and it goes without saying, that Anurag and Anurag's cases have been a blessing to us here in Kanpur, but all across the world, not only in India, but all over the world. People are here, people are enjoying the repertoire of cases that Anurag has is mind-blowing. And I'm very sure you must have learned a lot from this learned faculty and along with Anurag and all his fellows. One of his fellow is already managing pediatric endocrinology at KGMC Lucknow. That is Neha, who was, I think, the first fellow of Anurag, and he rightly as put in by Dr. Tripathi that this is a way it will spread all over. And thank you so much for attending in a good number, and all the best, Dr. Anurag, for the future courses. Thank you.
I'll request Vibha to give a memento of appreciation, Dr. Rashmi, please. This program is also associated with IAP Kanpur. Unfortunately, Dr. Yashwant, I think, has not been able to make it. We have got Dr. Amitesh Yadav. Dr. Amitesh, please come up and have a few words. So Dr. Amitesh is the secretary of IAP Kanpur. Very dynamic. I keep on seeing him posting a lot of work which has been done on part of that. So I was also the secretary with Dr. Rashmi. I think that was more than around 12 years now. So Dr. Amitesh.
गुड आफ्टरनून टू ऑल ऑफ यू। थैंक यू सर। आईपी कानपुर की तरफ से मैं आप सभी को कांग्रेट्स करना चाहता हूं इस अच्छी वर्कशॉप के लिए। जैसा कि त्रिपाठी सर ने कहा और रश्मि मैम ने कहा कि अनुराग सर पूरे कानपुर के लिए ही नहीं, पूरे इंडिया के लिए एंडोक्राइनोलॉजी के वरदान है। हम लोगों को कानपुर के बाहर जाने की जरूरत ही नहीं पड़ती। कोई भी इस तरीके का पेशेंट होता है, हम लोग रिजेंसी सर के लिए रेफर कर देते हैं। और सर को मैं बहुत बहुत थैंक यू करना चाहता हूँ। आईपी कानपुर का बहुत मन था कि सर के सुने कुछ ग्रोथ के बारे में हम लोग उनसे अपडेट लें, तो सर से थोड़ा सा कहने पर ही सर ने तुरंत तैयार हो गए। और आज कुछ रेजिडेंट्स भी हैं, कुछ आईपी के भी मेंबर्स हैं जो अब आप लोगों के साथ कंटिन्यू करेंगे। थैंक यू सर। थैंक यू मैम।
थैंक यू डॉक्टर अमितेश। मैं डॉक्टर विभा से रिक्वेस्ट करूंगा कि प्लीज डॉक्टर अमितेश को मोमेंटो प्रदान करें। So we'll start with our first module, which is on growth. I will request Alapan to come up. He will be helping me out. So this is more like a dialogue between the consultant and the fellow and the consultant's experts who are sitting there. So it's like a two-way communication. I will like to request Dr. Vijay Jaiswal, who is the head of department at LLRMC Meerut, to kindly join the dais along with Dr. Ayesha Ahmed, who is the additional professor at Medical College, AMU Medical College in Aligarh, and Dr. Arpita Bhraguvanshi, professor at pediatrics in KGMU Lucknow, to please join in. And we know that growth is a common cause of concern, and this is something which is extremely important to evaluate and assess from that perspective. So, so we have this 12-year-old girl with height of 132 and weight is less. Now, growth failure is a common problem. But most children who come to us with growth failure have a physiological cause. So growth failure is a common problem. 2.5% of all children are short. 80% of them have a physiological cause, while 10% will have a significant pathology. So our job as pediatricians is to not do unnecessary workup in these 80% while not missing these 10%. So this is the goal of this first module about careful assessment and management. Now, just roughly, this is a paper which I published a few years ago regarding the growth failure. So growth failure could mostly be physiological or pathological. In physiological, you have got two situations: constitutional delay or familial short stature. So you need short stature is a child who is short for the population. CDGP is a child who is short for the population, but is not short for the bone age. And familial short stature is a child who is short for the population, but not short for the parents. So 3 questions will really give you 80% answer. Is the child really short? Is the child short for the family? Is the child short for the bone age? And you will get that this is physiological or pathological. Now the questions you have to answer is it really short stature? Then whether it is physiological or pathological, and then within pathological, the problem could be in the growth plate. So you can have a problem in low birth weight, syndromic association, rickets or skeletal dysplasia, or in the environment. So your growth plate is normal, but either the hormones are not there or nutrition is not there. So next question is it nutritional or endocrine? If you answer these questions, your work is nearly done in that perspective. So what really is short stature? How do you define short stature? So we can use a statistical definition, but then everybody who is below the 3rd centile will become short. So what we try to look at is at what level of short stature do you have pathologies coming up in this regards. So what we found is that if you are less than -2 standard deviation score, or you're more than -2 standard deviation score, the chances of pathology is only 2%. If somebody is -2 to -3, the chance goes to 40%. Below -3, it becomes 80%. So if you have to evaluate anybody who is less than -3, immediate evaluation is required. -2 to -3, maybe you can wait and watch. And more than -2 standard deviation score, don't worry at all. Now, for people who are more accustomed in terms of percentile, if your percentile is less than 1st percentile, that is somewhere going around the 3 SDS mark, and 3rd percentile is going more towards the 2 SDS mark. So in a growth chart, and we have also validated that the IAP growth charts are working very well compared to the WHO or the previous Dr. K.N. Agarwal's chart. So these are our field trials as well as clinical trials which we have published have shown that IAP charts are very good. So use IAP chart, plot the chart. If the child is very short, the child is coming out here, height below the 1st percentile, he needs evaluation. If the child is just below the 3rd centile but not very short, better to follow up for some time. If the child is drifting away, that means short and not growing. If you want an objective definition, if the height is between 1st and 3rd percentile and growth velocity is less than 25th percentile, requires evaluation. But sometimes children who are not even short require evaluation. So if you look at this child, he was growing very tall, and now all of a sudden his height is coming down. So what you are seeing is that this child is not growing at all, which means crossing of 2 or more percentile lines between the age of 2 years and puberty. So very short, short and not growing at all. This is where your evaluation is indicated. Now the next question is it pathological or physiological? You have to look at growth chart, pubertal status, and bone age. These 3 things will give you a clue. So in a growth chart, what you want to look at is what is the absolute status? What is the percentile of the chart? Or better would be standard deviation score. We prefer SDS because this provides us a better objective assessment of growth failure. Then what are the parental expectations? We want to look at in terms of target height. And we know the target height is mother's height plus father's height divided by 2 plus 6.5 centimeters for boys and minus 6.5 centimeters for girls. And we can have SDS scores as well. And then we want to assess whether it is nutritional or endocrine. If you have a child who is short and plump, weight is less affected, height is more affected, this is an endocrine cause. While if you have weight more affected, this is a nutritional cause. So when I say nutritional, it means celiac disease, malabsorption, tuberculosis, RTA, while endocrine could be hypothyroidism, growth hormone deficiency, pseudohypoparathyroidism. So the most important thing to look at in a short child is actually the weight and not the height, which will tell you which way to go. So height, age, and weight age will give you a clue. We have developed a growth interpreter which provides accurate estimation about what's the current status and how do you reach a particular diagnosis. Very importantly, you have to look at the pubertal status and remember 2 stages, breast stage 2, from where you expect 20 centimeters of growth, and breast stage 4, from where you expect 10 centimeters of growth. If somebody has menarche, only 5 centimeters. So as I always say, if you have a girl with 130 centimeters at B2, you can expect 150. At B4, that will be 140. And menarche will be only 135. So without doing a pubertal assessment, you cannot really prognosticate where the girl is going to land up in terms of height. In boys, the most important thing is testicular enlargement. So testicular volume above 4 ml and growth spurt happens after 10 ml is important. Now, the next most important thing is the bone age. Unfortunately, most pediatricians are not adept at doing a good bone age, and most radiologists are worst because they will give even more confusing reports in terms of bone age. So the most important thing to look at in bone age actually is not the carpal bones, it is the distal bones, because the maturation happens from proximal to distal and fusion happens from distal to proximal. So if you want to assess your radius, ulna, carpal, it will be too late to assess. Very early, maybe carpal will have a role. Otherwise, you are mainly looking in terms of the long bone. And what we are looking at is the comparison of epiphysis and metaphysis. What is the size? So bone age assessment, you want an X-ray which has a full hand with spread fingers with proper exposure. And at different age groups, you can use different bones. This is just a rough guide. Most children between 3 to 12 years, you will compare the metaphysis to epiphysis, and this will give you a clue if it's small, big, or large to calculate the bone age. Now, we have got detailed bone age videos also, which are available on YouTube for over an hour also. You can have a look at that. So, but this is a very basic idea on that. Now, the conventional methods for bone age, including Rulich pile, Tanner Whitehouse, and the automated measures are not easily available to pediatricians because they need expertise, they need time, and they need money. Bone expert will need money. So we have developed a bone age application which really provides a very simplified bone age assessment by comparison of the 5 sites of bone age. And this we have published and we have found it to be very effective. And it gives around 2 minutes, you will get the bone age. And this has been published even for DNB students who have done a very reliable parameter. So this is something which is available in our mobile application. Now, once you know this is basically a short stature, next question is it CDGP or is it familial short stature? So if the child is short for the population, but is not short for the family, then you have a familial short stature. If the child is short for the population, but is not short for the bone age, this clearly means that this is a constitutional delay of puberty and growth. So family and bone age will give you a clue in this regards. And then if it's primary or secondary, look for the facies, look for the body proportions, you will get the diagnosis. And finally, nutritional versus endocrine. As I said, if you have this picture, weight more affected, this is nutritional. If you have this picture, height more affected, this is endocrine. And we have shown BMI standard deviation score below -1 is nutritional, above -1 is endocrine in most cases. So this is something which is important clue in that regards. Now, how do we go about? Look at the growth chart, puberty and bone age, look for facies and proportions, birth weight, very important, whether this is a SGA child. All girls in which you don't find a cause do a karyotype to identify Turner syndrome, genetics rarely, skeletal survey, and after everything is normal, you look at liver, kidney, celiac is a very, very important thing to look at, and blood gas in young children. Children below 3 years with growth failure should always have a blood gas to rule out RTA. After 3 years, do a blood gas only if you have features of RTA like rickets or acidotic breathing in that regards. And then, of course, thyroid growth hormone should be done only at a later stage. So all people should have a CBC, ALT, creatinine, TTG, thyroid profile. If needed, you can do karyotype if everything is normal in girls, and blood gas below 3 years of age. This is the recommendation that we have. And calprotectin for inflammatory bowel disease above 10 years of age. Growth hormone IGF assessment should be done only after you have excluded everything. And remember, growth hormone is a pulsatile hormone. Never do a basal growth hormone. That's a waste of money. Do a growth hormone stimulation test if you want to do a good diagnosis, and you may need to do priming in certain scenarios. IGF-1 and IGF-BP3 are markers, but they are not very good markers. So we don't do it routinely in terms of initial assessment. They are screening tests in that perspective. So how do we approach growth failure? We have developed the algorithm which is simplified, which saves cost. So first look at height SDS. Above -2, reassured. This is normal. -2 to -3, next question, short for the family. Yes, you need to evaluate, not short for the family. This is familial. Next stage, is he short for the bone age? If it's not there, this is CDGP. Otherwise, then you need to start evaluation. Then you do screening test. And if screening tests are normal and everything is there, he's not growing at all, then only you go ahead in terms of evaluation, do a karyotype, and after all that, do a growth hormone stimulation test. So this protocol is largely clinical. It is looking at puberty. It is looking at bone age. It is looking at some basic tests and doing complicated tests only at a very, very late stage. So this is how we want to go ahead in terms of evaluation for this assessment in terms of growth failure and identify the cause from that regards. Based upon that, because this looks a bit complicated, we have developed an algorithm which published in JPEM, where we found that we had a 98% concordance with clinical diagnosis using the mobile application from that regards. So having set the background, we'll now go through the cases. Dr. Alapan, you can start off with.
So good afternoon, everyone. Our first case is a 12-year-old girl presented with height of 132 centimeter and weight of 28 kg. Our father height was 164 centimeter and mother's height was 151 centimeter. So Dr. Vijay sir, I would like to know how do you proceed further in this case?
Yes, thank you. Though these are the numbers, I would like to plot these numbers on the growth chart, please. Yes. So now what I can see here, that this is a 12-year-old girl. Height was 132 centimeter, weight is 28 kg. Father height is 164 and maternal height, mother height is 151. So if I'm going to see the two parameters first for the particular child in terms of height, age and weight age, then they are corresponding to the same. That is about 9 years of age we can see here. Second, that what we can see, whether this child initially was looking short on the growth parameters on this growth chart, but whether it is really short. So if we are going to see that there is no fixed number, so mid parental height is 151 centimeter. And we all know that there is a range. There is no fixed number. So plus minus 6 centimeter of 151. So it came to be 145 to 157. So if we are going to extrapolate the findings, we can see that this 12-year-old girl is looking short, maybe looking short for the population, but she is growing very well according to mid-parental expectation. So I don't do any investigation. Rather, if there is concern, then I'll do the follow-up and counsel the family. Then whatever you are doing, it is right. And we will see after another 6 months.
So sir has explained excellently that this is a case of a familial short stature, which require follow-up but doesn't require any intervention at that particular point of time. On further follow-up, for the last 6 months, her height was 135 centimeter with a growth velocity of 7 centimeter per.
Yes.
With a growth velocity of 7 centimeter per year. And now this is the growth velocity curve, as you can see. Sir, I would like to know your opinion about the further growth of this child.
Yes. So it is a very good question. So what we expect, that growth velocity is not a fixed number, one. Second, that is what is abnormal growth velocity. So abnormal growth velocity is not the velocity below 3rd centile, but rather below 25th centile. So it means that growth velocity is more sensitive indicator to assessment of growth or to see the trajectory of the growth. And here I can see that growth velocity of this particular girl child is much more above the 25th centile. So we can assure that your child is doing very well. Whatever you are doing, that should be continued. There is nothing to worry about that. This is going to attain the mid-parental expectation. That is the best of genetic potential.
So as I has explained that after assessing the height on the follow-up, we look for the growth velocity also. And if it is more than 25 percentile, we shouldn't bother much about this thing. And in our case, the growth velocity percentile was 50 percentile. So we should.
Okay. Okay.
अच्छा उसे कर देते हैं side. वो नहीं, कोई बात नहीं.
So
Yes. So the practical point is that correct height for the parental expectation. So don't interpret just only with a single height. One. Second, that you have to measure the parental height. वो ऐसा नहीं हो सकता कि माँ अच्छा 5 फुट 2 इंच की होगी. No. You have to measure the height. If someone is absent, तो जो भी आप इन्वेस्टिगेशन बोल रहे हो वो करा के, और जो एब्सेंट था उसको बोलो कि वो नेक्स्ट टाइम पे जो आपका जनरल ये है टेस्ट है उसके साथ हुआ जाए. So you will be in a better position to evaluate the mid-parental height. And then if you are going to see, so you can see that growth velocity is the crucial, and that is the most sensitive indicator for the growth, not the absolute height. So this is the take point.
So moving on to the next case, a 13-year-old boy having height of 135 centimeter and weight of 30 kg. His father height was 169 centimeter and mother height was 156 centimeter. Dr. Aisha ma'am, I would like to know your opinion regarding this case.
So the same thing I would like to reinforce, that whenever you encounter a child who comes to you with short stature, the first thing should be that you should plot his or her height on gender specific IAP growth charts. Okay. So as you can see, both height and talking about height is below the 3rd centile on the lower side, while weight is not affected that much. So the second step should always be, you should plot the mid-parental height along with the range. Okay, so whenever the height is on the lower side, so you always have to look whether the child is short for the family or not. And always keep in mind, again, the same thing, you have to look at the child, whether there are not any clinical pointers in the history or the examination which suggest any kind of syndrome. So this we are talking about in a child who has nothing else apart from a short height. So the mid-parental height is roughly about 169, I think. 169.
Yes, 160.
And the height age, definitely, he's a 13-year-old child, an adolescent, and the height age and the weight age, they are affected, but at the same point. And the testicular volume is just 3 ml. So still at a point, we expect him to land up into puberty, but still we have a year to label him as a testicular, as a pubertal delay, because we label it till 14 years. So you just have to see.
I think we have residents also here. So maybe Dr. Aisha, you can just explain about the height age, weightage concept, because that is something which is very important.
Okay. So height age and weightage is basically you compare what the child's height is against what is expected for that age. Okay. So height age means this child is on chronological age. If you say he's 13-year-old, so it's on the lower side. So what you do, you draw a horizontal line where it crosses the 50th centile and drop a perpendicular to know about the height age. So height age is coming at it's 9 years. 9 years. And also the weight age. The same thing you do for weight year. So as it was very correctly pointed out, if both things are affected, like height and weight, both are coming at the same thing, that goes maybe in favor of nutritional causes. While if there is any discrepancy, if height is affected more as compared to the weight, so you have to always think of endocrine causes in such a situation. So that is the importance of plotting height age. You have to see what the person's height and weight is falling along both centiles.
So the further workup has been done,
Okay,
and
so
the screening tests were normal. Someone did a basal growth hormone level, which was low. So ma'am, do you think this child requires the basal growth hormone assessment in this scenario?
So talking about workups, you always have to start in a tier-wise manner. So you always send the first line investigations. So in this case, everything was normal. So somebody ordered a basal growth hormone. So here I would like to say basal growth hormone, as it was very rightly pointed out, it has a single value has got no importance at all. So either it has to be a stimulated test always. Okay, so basal growth hormone, even on the low side, does not carry any value because it has pulsatile nature in secretion. So you cannot really comment upon based on a single reading.
As
So
ma'am
growth
has
hormone.
As ma'am has explained that basal growth hormone level, a single value of basal growth hormone level has no implication. The growth hormone stimulation test showing a peak growth hormone of 6.2.
This is also on the lower side.
Now,
So here the catch is, so this I was talking about growth hormone and stimulation. So now look at the age. So there is a slight difference, like in young children, you can go for growth hormone stimulation test wherever you suspect growth hormone deficiency. But in peripubertal children, there is a role of priming. So you have to prime them. Like there are many cases of CTGP who may show, even on stimulation, may show falsely low levels. So you have to prime them before going for growth hormone stimulation test, prime them with testosterone in males and estrogen in females, and they may have a good value after that. So we did priming, and the peak growth hormone was very well within normal range. So this is the take-home message. In peripubertal children, they have to be primed with steroids before going for growth hormone stimulation test.
And if you just look at this growth chart, maybe all of you can have a look, you see the child is just below the growth chart. If it was really growth hormone deficiency, the height would have been much, much below. 99%, 99.9% of these boys who are prepubertal at this growth chart will not have GHD. So don't really think of GHD, think of common causes.
So always,
then, yeah.
That calls the importance for always checking for standard deviation scores, always. So that gives you a clue how far the child is lagging behind. So more than 3, as sir said, definitely. So the lesser the SD scores, more the chances the child may have any pathology, significant pathology.
And if I just go back to what I was talking about, he's short for the population. He's short for the family. But the yellow dot you can see, we have plotted the yellow dot at the bone age. He's not short for the bone age. So unless he meets these 3 criteria, you will not call it pathological. This is the physiological form. This is constitutional delay. And unfortunately, if you don't do a primed sample, you will have a low GH, which is of no consequence. And he will continue to grow normal. Yes. So priming, sex steroid priming basically means that people have seen that if a child is prepubertal, his growth hormone levels are low. But once they enter puberty, the growth hormone levels increase. So if you have a child who is prepubertal like this boy, if you do growth hormone stimulation, it may be normal. It may be low, but he is normal. So in that case, best to give him testosterone, or girls, you give estrogen before to really check for the growth hormone level. This requires a lot of evaluation. So ideally, growth hormone stimulation should be done by centers who are managing that, but you need to have an idea that don't do a basal growth hormone and don't do an unprimed sample in this regards.
okay, so moving on to the next case, a 15-month-old girl with a birth weight of 4 kilogram, mid-parental height was 150 centimeter, failure to thrive, and diagnosed as RTA. Arpita ma'am, I would like to know your opinion regarding this.
Right. Thank you, Alapan. So this is a 15-month-old girl with a bigger child. So she was LGA to start with, while the MPH was not very high. So I would like to go back to the antenatal history and look for any evidence of gestational diabetes, or in the mother, the history I would like to know. And then the investigations, what were the base X's and...
Okay, so the growth chart, as you can see in this child, the growth trajectories are followed, and there was a normal investigations, routine investigations were normal, and as diagnosed was RTA, so someone did a BVG level, so base excess was -7.
Right. So it was just mild acidosis, and it was labeled as RTAs. The thing which we have to highlight here is that the baby was LGA, so the size at birth is determined by the environment, and the size at adulthood is determined by the genetics, and the switchover somewhere occurs at 2 years of age. So the point that the child was crossing the centiles and was labeled as failure to thrive was actually physiological in this child, and it was a normal catch down growth which is happening. So it was a normal physiology which was wrongly labeled as a pathology, and this child did not need any evaluation, and this is a normal catch down growth which usually happens in an infant of diabetic mother.
So
as Dr. Arpita has mentioned, this child was destined to be short, but was born large because of environment. And this common finding is not going to be of much change. Don't worry about this. So don't do unnecessary workup in this regard. So we are missing physiology and making it as a pathology.
So again, the practical points as explained by ma'am. Now the next case, case number 4, 10-year-old girl with height of 120 centimeter and weight of 15 kg and diagnosed as growth hormone deficiency. Dr. Arpita ma'am, I would like to know your opinion on this. Okay, so growth chart is here.
So here we can see that the weight age is more affected than the height age. So it points towards a nutritional cause of short stature. So we'll go for the routine investigations and also for the TTG to look at celiac and malnutrition like conditions. So can I have the report?
Yes, so we have done the routine investigations which appeared normal and TTG level of 12 with karyotype of 46XX. And IGF level was done, which seems to be a bit low. And again, the basal growth hormone level was 0.5.
Okay. So actually in a malnourished child, IGF levels have no value. So this does not hold any value. And we know that basal growth hormone also does not have any value because the TTG was not very high. We could have gone for a total IGA.
Yes.
If IGA is also low, it can be falsely low in this patient. So
growth chart, please. So I just want the residents to have a look at this growth chart. Which thing is more affected here? Is it the height or the weight? What is more affected in the growth chart? Height or weight? Louder? Weight. So this cannot be an endocrine pattern growth failure. So before you reach a diagnosis based upon investigations, look at what you are seeing on the growth chart. The most important investigation in a child with short stature is actually the growth chart. So this chart, just put in your mind, this is not GHD. And very nicely, Dr. Arpita said, this looks like celiac. So why are we asking for IGA, Dr. Arpita?
So if the total IGA is also low, so this may be falsely.
Yes. So around
labeled as
10% children who have celiac disease are IGA deficient. So if you do a TTG, which is also a IGA, may be falsely negative in that. That is why Western guidelines say do IGA in everybody. But then the cost will come too much. So if the TTG is normal and you have clinical features, then you do a IGA level.
Okay, so as ma'am has explained that IGF level is dependent on age, nutritional factor, and we should not straightaway go with the IGF level before going up other normal screening investigation. And in this child, the IGA level was undetectable. So also we have ordered for an duodenal biopsy, which shows villus atrophy. So I think the diagnosis is clear from here, and the child was advised as a gluten-free diet in the diagnosis of celiac disease. So the practical points, ma'am, you would like to highlight in this case?
So we need to look at the nutritional cause for the short stature if the weight is more affected than the height age, and IGA should be ordered if the if the TTG is falsely low, and IGF levels are not actually required in a malnourished and a young child, and there is no role of basal growth hormone levels.
So moving on to the next case, a 8-year-old boy presented with height of 100 centimeter, weight of 18 kg. This times he was diagnosed as celiac disease. Dr. Vijay sir, I would like to know. So I am repeating again the case 5. Okay, I'll just sing. So 8-year boy with height of 100 centimeter, weight of 18 kg, diagnosed as celiac disease. And this is the growth chart of this child. So do you think this is a celiac disease?
No, again, the basic thing is that we have to plot these numbers and we have to interpret it. So what we are going to see that what is the most affected parameter, that is height is. So both things are affected, height is as well as weight is, but the most affected parameter is height is. So in case of relatively maintained weight, and the predominant deceleration or predominant problem is height, it means that it is this short stature is going to be an endocrinal problem. So in one line, what I want to say you in a very simple word, that chota or mota bacha agar hai, so it means that your antenna should be alerted and you have to dig out all the history. Again, you have to evaluate the child. And according to that, you have to find out that what is the cause of this reduced height is. And accordingly, we have to plan for this. So I want to see the first systemic parameters, and then yes. So I can see here that hemoglobin is normal, a normal creatinine and a normal liver function test. TSS is also normal. TTG, a bit I am skeptic for this number, but growth hormone, this is a single digit. I want to do one, that is bone age first, and the second, that is growth hormone, that is dynamic stimulation growth hormone test.
So there was no effect on gluten-free diet in this child. So he was advised gluten-free diet. And if we have consideration about the height, weight, and weightage, sir had explained already that nutritional causes will cause much more effect on the weight rather than height, and the endocrinal cause at the same time will cause much more effect on the height rather than the weight. So weightage and heightage will roughly give you an idea about whether this is an endocrinal pattern or a nutritional pattern of short stature. So further workup, duodenal biopsy was advised in terms
Yes.
of the high, slightly high TTG level, and it was normal.
So just again for residents, that if the things are not clinically correlating, again you have to recheck the things. So doesn't go with number. You have to see the oxology. You have to see the all other. So in total, you have to see. You don't have to see in bits and paper. So you have to, if you really want to solve the puzzle, you have to join all the things together, and you have to look at the big picture. So bigger canvas, and you are going to make the diagnosis. So yes, I would like to see the growth hormone stimulation test.
And the peak growth hormone level in the stimulation test was 1.
So yes. So initially we were saying that any growth hormone level beyond 10, but since we are having very good sensitivity method nowadays, so any growth hormone level which is beyond 7 nanogram per ml, then it means that there is no growth hormone deficiency. So if this is 1 picogram per ml, this is really very low. It is severe growth hormone deficiency, and this child will require treatment. So before that, we have to see that why this child is having relative less growth hormone. So we have to see whether there is hypofunctionality of the pituitary, or there is some mass effect or something like that. So here we can see that pituitary size is hypoplastic. Why there is hypoplasia? Because if you are going to see, the most volume of your pituitary is going to be devised by anterior pituitary, and even in anterior pituitary, it is mostly devised by somatotrophs, that is growth hormone producing cells. So that's why we can see here that this is the cause, hypoplastic pituitary leading to growth hormone deficiency.
So as the diagnosis of celiac disease, Spagan has recommended that initially we should go for the TTG level. If it is even negative, then we can go for the IgA level. So if IgA level is positive, then we can further go for the biopsy to confirm the diagnosis. If the TTG level is more than 10 times of the upper limit, then we have another option of endomysial antibody, which is, if it is positive, we can stamp this child as celiac disease. If endomysial antibody is negative, we have to further confirm it by using a biopsy. And if it is between 1 to 10 times of the upper limit of the normal, biopsy, we can confirm the celiac disease by using a biopsy. So moving on to the next case, a 6-year-old boy, height of 90 centimeter and weight of 12 kg, diagnosed as nutritional ricket and given multiple doses of vitamin D. The X-ray is showing features suggestive of rickets, and the baseline investigation is like this. So Dr. Ayasa ma'am, I would like to know whether you are considering this child as a case of nutritional ricket or not.
Yeah. So this is a very common scenario. We often see children like this. So you can see he looks like a child of rickets with the clinical features, and he has received the dose of vitamin D and calcium, which is expected, and he has not responded to treatment. So if you remember what I had talked yesterday, that in a situation where you have more involvement of the lower limbs, and especially you have a catch here, like the child has not responded to your usual vitamin D and calcium supplementation, to always think of secondary rickets. So which could be calcipenic, which could be hypophosphatemic, or which could be vitamin D resistant rickets, or even because of multiple reasons like RTAs, like renal failure. So always suspect causes of refractory rickets in such a situation. So phosphatemia is very common, but as we can see in the biochemical parameters here, it's within phosphate levels are within normal limit. So the next step would be you have to check for acid ABG analysis to look for whether it could be because of RTA or not.
So
once
ABG
we have the
analysis has been
report,
done,
yeah.
and pH was 7.1 with base excess of -15
Yeah.
with the urine anion positive.
Okay, so result is itself very clear here. So it was actually a case of RTA, and the clinching point here was more involvement of the lower limbs and not responding to your usual treatment. So this was RTA. Then you have to differentiate between the proximal and the distal RTA. So the helpful test would be checking for a urine pH and this bicarb CO2 difference. So urine pH was 6.8. So that goes in favor of distal RTA. And also don't forget to check for features of nephrocalcinosis, because that is more common in distal RTA. So you have to send the investigations accordingly.
Okay, this child has also features of nephrocalcinosis as seen by ESG. So the next case, case number 7, a 14-year-old girl with height of 120 centimeter and weight of 32 kg. You can see the child, ma'am. The initial screening investigations were normal. I would like to know, you would like to inform any test, or you would like to see any further clinical features in this child before proceeding?
Okay, so as mentioned already by sir, any short girl presenting to us, any short girl coming to us with growth failure, we have to consider Turner's syndrome as a possibility. And on looking at the child itself, there are pointers clinically for Turner's. If there are no clinical pointers, then too we have to suspect Turner's and order karyotype, an extended karyotype with a 50 metaphase to rule out Turner's, because it may be a mosaic Turner, and an extended karyotype will help us find out the Y cell line, because Turner's may have a Y cell line which may progress to cause gonatoblastoma in the later on period. So this girl, definitely she's a walking Turner's. We have to have a high index of suspicion here and order an extended karyotype along with FSH, which will be supportive in this patient. So
as explained by the ma'am, a short child, girl child especially, with features of Turner stigmata like widely spaced nipple, brachymetacarpia, waved neck, we should always consider the Turner syndrome.
So there are,
this is brachymetacarpia is present in the
there is brachymetacarpia in the second one, and there is widely spaced nipples and shield-like chest, and webbing of the neck is also seen in this child.
So karyotype was further ordered, and it was like 45X in this case, and diagnosed as Turner syndrome. So
we need to also screen these girls for other associations. So USG KUB should be done to look at horseshoe kidney and other kidney abnormalities, hearing screening, and most importantly, echo and cardiac MRI should be done in these children, because there are left-sided heart lesions, and which is the most common cause of death in these children. And there is no need for growth hormone stimulation test in children with Turner's. You can straight away go for growth hormone therapy in these children.
okay, so moving on to the next case, a 5-year-old boy with birth weight of 2.1 kg. So as SGA child, having complaints of poor growth, but a normal development. His height was 90 centimeter and weight of 10 kg. We can see it in our growth chart. The height is affected, also the weight. Dr. Aisa ma'am, I would like to know your approach in this case.
Okay. So we have a child which was born small.
Yes.
Okay. So as it was suggested by Dr. Anurag sir, for SGA babies, you have to wait for a particular period of time for 2 years. Most of the babies, 85% of them, they achieve their normal height, while by rest of them, like 5 to 10%, they achieve at the most by 4 years of age. So you have to wait till then. So we have a 5-year-old boy, and the height you can see is very well below the 3rd centile. So definitely you want this warrants further workup in this child. And okay.
Okay. So
Okay, so what that says is that SG babies, as I said, 10 to 15%, they will be born small and always remain small. But that is because there is a time period, so you have to wait whether this baby falls in the 85% categories who has a good catch-up growth, provided adequate nutrition has provided, and he carries and goes very well as compared to the normal peer group. But the 15%, they remain short, so you have to wait for that period. And that's what I would like to. So they have maximum catch-up growth by 2 years of age.
Yes. Yeah. So before labeling as a cast down growth, we have to always wait for some times.
And
before-
having a rapid growth is not a good sign here. More chances of having metabolic syndromes and morbidities as they grow older.
Yes. So we have to always wait for at least 2 to 4 years before labeling them as cast down growth, and a rapid growth in this period might predispose them for further complications like metabolic syndrome or precocious puberty in that scenario.
Diabetes later in life.
So the next case, a 10-year-old girl child with height of 112 centimeter and weight of 24 kg. You can see the child. Initial screening investigations were normal. Dr. Vijay sir, I would like to know your approach in this case. What you would like to do further?
Yes, thank you. So please plot on the growth chart. And what I can see with this picture, if you are going to see the dysmorphism is there.
Yes.
And upper to lower segment ratio, if you are going to see, again, this is skewed. So I would like to see other parameters.
So anthropometry has been done, and a
Yes.
short child with upper segment is to lower segment ratio is 1.5:1 in a 10-year-old girl child.
Yes. So just I want to see that whether this is abnormal girl. So skeletal survey and other things to rule out skeletal dysplasia will be my priority to see that how the bones are growing.
Alapan, what is the normal upper segment to this age?
At this age, around 1:1 or 0.9:1.
Yes.
around.
So normally it is like 1.7:1 and it gradually comes down. So this case, what we are seeing is that the upper segment to lower segment ratio is too much.
One. So before jumping into screening investigation and everything, we should always go for the history and the clinical examination as well as anthropometry. I think is the most important part that always should not be overlooked. So in this child, mutation of FGFR mutation has been done. Anyone diagnosis?
This is a walking case. Residents, I think this is very clear. This is achondroplasia.
Achondroplasia is the diagnosis. So the next case.
Dr. Alapan, can you go back, please? Just one second. Yes, please. So this was a case conundrum, and just I want to say that before doing the genetic test also, even parental examination is also must. So parents का phenotype कैसा है वो भी देखना बहुत जरूरी रहता है, because milder skeletal dysplasia with short stature even can be a presentation. So it is always to again go back with a good clinical examination of the parents also.
So often you will have hypochondroplasia, which is there in the parents. They will have short hand and they will be able to identify that. Very important point by Dr. Vijay. Now, before we wind up towards the next part, we now have a lot of obese children who are coming to us, and obesity is becoming a bigger problem actually. So obesity is more common as compared to short stature. Here, 98% have physiological cause, only 2% have pathology. So you don't want to do workup unnecessary, but this physiological people can actually develop diseases. So as I said, ki obesity is not because of a disease, but it becomes a cause of disease. So this is something which is extremely important to understand. So obesity can be physiological or pathological. Physiological obesity means normal growth, normal puberty, normal development. If your child has normal height, weight, development, think that this is a physiological cause. If there is hyperphagia, vision abnormality, pubertal developmental issues, very early onset, think of genetic obesity, especially before 2 years of age. If there is severe hyperphagia, think of hypothalamic obesity. Endocrine causes are rare, but you have short and plump child. That will be the cause of endocrine cause of growth failure in that regards. So our criteria for evaluation is if you don't have any obesity criteria, do not do workup. If yes, you go for age less than 5 years, very obese. In that case, you have to do a genetic study. If, however, it's less, then look for syndromic features. development, vision, and dysmorphism. If they are abnormal, go for genetics. If they are normal, look for height. If height is low, do for endocrine workup. If it's normal, complication screening. So your main is clinical first, age and clinical parameter, then you decide about whether you want to do workup. We have developed a obesity interpreter based upon you put some basic findings, and we have done a validation study which shows a very high rate of concordance, and we found that the interpreter gives the right diagnosis in around 98% of cases in that regards. So we'll start off with the cases of obesity now.
So the next case number 10, 12-year-old boy with obesity, height is 160 centimeter and weight of 70 kg. The height is not as short at this age of child. TSH investigation, someone did the routine screening workup as well as the thyroid profile, and TSH was 7.91, and he was advised thyroxine in this case. Dr. Ayesha ma'am, I would like to know your opinion regarding
Again, a
thyroxine.
common scenario and dilemma situation that we frequently encounter, because obesity is so common these days, and every clinician has this habit of sending investigations, especially thyroid, attributing thyroid to be the reason for the child's obesity. And often the result comes like this. So always remember, you don't treat just a single report. You have to see for thyroid hormones, the T4 levels also. So isolated TSH does not make any sense. So you have to look at the hormones. And also remember that in obese, this TSH, high TSH level could be the effect of obesity. The reason being, can you come to the chart, please?
Yes.
Because the obese children, they may have high leptin levels, and this might stimulate the TRH, leading to it falsely elevated. So TSH, a baseline elevated TSH in a child who presents with obesity is the cause of the obesity itself. So does not warrant any treatment. And one thing I would like to add, like normal physiological obesity, what happens, you will see a child who is obese and also very tall, as compared to the pathological causes or endocrinal causes of obesity, where you will have a child who is obese and short. So keep this thing in mind. So don't treat isolated TSH. This could be very well a result of that. And just you can reassure the family and just follow him up.
Important thing to look at in a short child, I said, was weight. The most important thing to look at in a fat child is the height. If he's tall, it is more likely a exogenous constitutional physiological obesity. If he's short, this is a pathological obesity. Very, very simple message, I think, from Dr. Ayesha, very important message.
So the next case, 12-year-old girl with height of 130 centimeter and weight of 58 kg. The screening tests were done initially, which was normal, and her parents were reassured. So again, he developed rapid weight gain. Dr. Arpita ma'am, I would like to know your opinion whether this reassurance was significant or not.
Right. So in any case of growth failure or growth excess, we need to plot the weight and the height in the growth chart and look at the weight and the height. So as ma'am had already pointed out, any exogenous or physiological obesity will be a tall individual and obese individual. So here we can see that the height is less and she is an obese girl. So this points towards an endocrinal. So as mentioned already, a short and a plump child, we have to think for the endocrinal causes. And if we look at the girl, she has a typical Cushingoid faces with round faces, and she has a buffalo hump also seen. So we have 3 endocrinal causes like hypothyroidism, Cushing's, and pseudo-hypoparathyroidism. This one specifically looks like Cushing's, so we need to go for an overnight dexamethasone suppression test, and it was not suppressed and pointing towards a Cushing's
syndrome. Okay, so the next and the last case, 3-year-old girl with rapid weight gain. Height was 84 centimeter, weight is 26, and she had some severe hyperphagia since birth. Routine investigations were all normal. She had normal development, vision, and infection, no history of any infections. So, sir, I would like to proceed further for this case.
In this case, what I can observe that the rapid gain was started since very early, one. So pathological thing, that is pathological appetite. And again, you can see the other parameters, the normal development, vision, and infection. So again, since the insult was started very early, so +3 standard deviation score of this thing in less than 5 years of age child. So genetic study is really required in this. So here, so yes, so I can see here that genetic study was done and leptin was undetectable. So this is a case of leptin deficiency. So it means that all the children who are presented to you with increasing weight doesn't always say that this is a case of simple exogenous obesity. So again, a good history taking, the pointers toward that what time insult has been appreciated, and then accordingly we have to plan and observe the things.
Okay, as Sir has always said about the 4S, like soon, that means if the obesity is very early onset, severe, syndromic, and segregating, that means there is a family history, or we should always look for the genetic cause. And as in this case, there was severe hyperphagia and early onset of obesity, we should go for the genetic study, and the genetic study showing a leptin deficiency in that scenario. So thank you, sir.
Okay, thanks a lot, Dr. Alapan. And at this, we'd like to thank the panelists, Dr. Vijay Jaiswal from Meerut, Dr. Ayesha from Aligarh, and Dr. Arpita from Lucknow for discussing about this very important issue. We will request Dr. Alapan to give a memento of appreciation to Dr. Arpita, please. So we'll move forward now to the second session on calcium grand round. And I have the pleasure to invite Dr. Rashmi Kapoor, the President of Growth Society, as well as the Chief Pediatrician at Regency Healthcare, Dr. Mahesh Maheshwari, Professor of Pediatrics at AIIMS Bhopal, Dr. Deepak Gupta, Pediatric Consultant at Janakpur Medical College in Nepal, and Dr. Vibha Yadav, Consultant Pediatric Endocrinology at Regency Healthcare in Kanpur. So we are going to talk about calcium, and calcium also is a very, very important phenomena. We'll use the same approach, a basic template, and then we will go forward towards case discussions on that. So when we talk about calcium, we should know that circulating calcium is only 1% of the entire body calcium. 99% of calcium is in the bones, and most of it is locked there. So you are not able to get it out. Now this calcium basically is then, once in the blood, is bound to albumin in 40% cases and phosphorus in 10%. But the free calcium is what is very, very important from our perspectives. So conditions wherein your phosphorus level goes up, your ionic calcium will become less. If your albumin becomes more, you will have hypocalcemia in that regards. Now, when would your albumin levels go up? So basically, if you have alkalosis, the ionic albumin, negative albumin will become more, the calcium will be bound more, and you will have hypocalcemia. And this is something you have to worry about. So if you are having hyperventilation, respiratory alkalosis, or somebody is giving soda bicarbonate, that causes tetany to develop, and this is important from that regard. So ionic calcium is what we are really looking out in terms of evaluation. So as I said, if you have alkalosis, you will have deficiency of ionic calcium, which will cause a problem of hypocalcemia. Now, calcium homeostasis basically has got three major organs and three major endocrine systems which are working. So we have got the bone, the kidneys, and the intestine. The most important acute regulator is the bone. The long-term regulator is actually, of course, the intestine. And there are three major hormones. Calcitonin is a hormone which decreases calcium. PTH is the one which increases, and calcitriol also is the one which increases through the intestinal absorption. The most important hormone here is PTH, and PTH increases calcium levels, also decreases phosphorus level. Anybody who has low calcium should have high PTH and therefore low phosphorus. So hypocalcemia should have hypophosphatemia. High phosphorus with a low calcium is a very, very direct indicator of a parathyroid related cause. So the most important investigation when you're looking at anything, look at what is most important. Phosphorus is most important from that regards. Now this calcium is sensed by the calcium sensing receptor. Now when should you suspect hypocalcemia? There are very non-specific manifestations, but anybody with seizures measure calcium. Unexplained cardiac failure, intracranial calcification, a common referral from neurologists. They have seizures and then they do a CT, they found basal ganglia calcification. This is long-standing hypocalcemia. Raised intracranial pressure, stridor, and long-standing hypocalcemia will also cause cataract. Any preterm below 36 weeks, birth weight below 1500 grams, and conotruncal defects should be evaluated for hypocalcemia because that could be DiGeorge syndrome in that regards. Now, calcium should be done in a fasting state. It can be low in hypoalbuminemia. So best is to do a ionic calcium or you use a corrected calcium in that perspective. In that regards, you can say for every 1 gram decrease in albumin, the calcium goes down by 0.8. So you can actually use this sort of a cutoff to identify that in that regards. Phosphorus should be first thing in the morning in a fasting state. Very importantly, do not use a tourniquet or a squeeze sample. Where is phosphorus in the body? In the cells or out of the cells? It is an intracellular ion. So if you squeeze like potassium, phosphorus, magnesium, their levels can really go up. So you should never use a squeeze sample and you need an age-specific level. Often the reports that you see actually are adult levels. So you can't use adult levels. Infancy, the levels can go up to 8. And childhood, they can go up to 6. So these are the cutoffs that you want to use. And adults, the cutoffs are lower. So don't go by the adult cutoff in that regards. Calcium and parathyroid hormone have a log linear relationship. So if your calcium is low, your PTH should be sky high. If your calcium is high, PTH should be 0. So if you have normal PTH with low calcium, this means the PTH is actually low. So you have to interpret in the light of calcium levels. PTH is very thermolabile. If you do not process it immediately, do not send it in ice, the level will always be low. So if you send to a collection center, the person goes and keeps it for hours, your PTH will be 0. You will not have much value. So always do it immediately. So if your calcium is low, PTH should be very, very high. If your PTH, however, is low, and I say less than 70, then you think of hypoparathyroidism in that regards. So hypocalcemia, the common causes are vitamin D related or PTH related. The most important test is phosphorus. High phosphorus with hypocalcemia means a PTH problem, hypo or pseudo hypoparathyroidism, or rarely a renal failure. If your PTH is high, that is a normal response. But if you have a low PTH, it of course is a hypoparathyroidism. Then you can look at the vitamin D level and calcitriol. I would say the most important is phosphorus, PTH, and creatinine, which will give you the right clue in that perspective. We have developed a calcium interpreter in which if you can just enter the values of calcium and sequentially enter the other values, you will get the right diagnosis in that perspective. So a combination of these parameters will give you a clue. An interesting thing is urinary calcium. If your calcium is low, your urinary calcium should be low. Body want to conserve it. But if you are losing, it means that the body's sensing of calcium is defective. So approach is you look at first of all hypomagnesemia, hypoalbuminemia, and phosphorus load. If they are not there, look at phosphorus. Low phosphorus, vitamin D related. High phosphorus, PTH related. So the phosphorus is low, get a vitamin D for vitamin D deficiency or resistance. If you have a high phosphorus, look at creatinine to identify a renal failure. And if it's not there, for PTH related causes, that's the thing. So first case, we'll start 4-month-old boy with nephrotic syndrome. Calcium is 7.2, child is asymptomatic. Dr. Rashmi, do you think this calcium is extremely low?
Hello. So we know that calcium 40% is bound to albumin, and we've not done a ionic calcium. I would like to know either the ionic calcium or the serum albumin levels. So here we go. Serum albumin were 2, so we can use the corrected calcium values. So as measured calcium plus 4 minus albumin into 0.8 milligram per deciliter. So corrected was 8.8, which was almost normal. So this, we will not label this case as a hypocalcemia. This, as albumin becomes normal after treatment, this calcium is going to become all right. But nevertheless, in nephrotic syndrome, we should give calcium supplement because vitamin D takes the calcium out of the bones, and
especially if you're on steroids, you have to give
and if you
So a very important message by Dr. Rashmi that you correct for albumin level or you go for ionic calcium. Now, ionic calcium is readily available. One caveat is that often when you get the blood gas report of calcium, I am not very happy with those reports. What's your opinion, Dr. Rashmi?
So actually you need different probes for electrodes for measuring different ions. So you have to update and match those probes every time. So sometimes electrolytes are not matched, especially so calcium. Sodium, potassium almost give the accurate values, but not the calcium.
So the blood gas reported ionic calcium, be cautious unless you have a very regular standardization of the machine which is happening on that regard. So ionic calcium is preferred. 4-year-old girl with tetany with an ionic calcium of 3.1. So this is low. Phosphorus is high. PTH is also high. Diagnosed as pseudo-hypoparathyroidism. Because we say hypocalcemia, high phosphorus, and then you are saying PTH is high. This is pseudo-hypoparathyroidism. Dr. Mahesh, do you agree with the diagnosis?
As you said in the beginning only, that first thing that you need to rule out, whenever there is a high phosphorus, there are three possibilities. Either there may be a phosphate load, or there may be a renal related problem, so maybe chronic kidney disease, or there may be a PTH related problem. But the first and the most important thing that you need to remember, always do the creatinine before making a diagnosis of pseudo-hypoparathyroidism. So what is the creatinine level in this child? As we see here, the creatinine is 2.4. And that is comparatively more common and more on a higher side. So the diagnosis is actually in this condition is CKD.
So very important, do not avoid the algorithm. Don't do unnecessary expensive test. Do a creatinine first. This was very, very high in that
At
regard.
the same time, you should not also need to see the clinical presentation.
Yes.
So in clinical presentation, if there is a if there is an acidotic breathing, short stature, anemia, then probably you're dealing more with a chronic kidney disease.
1-year-old boy with seizures, calcium is low, 5.4, phosphorus is high, is reported 6.1, so not that high. PTH is 11, so PTH is low for the level of calcium. Definitely, there is no response to IV calcium. Dr. Deepak, what do you think? This is hypoparathyroidism?
No, before ruling out all those endocrinological causes, we have to look for the basic causes of seizure like electrolyte, glucose, magnesium. So we should first rule out all these basic causes. So can I know what is the magnesium level, please?
Yes. So as you said very rightly, if you have refractory hypocalcemia, before you do much, do a magnesium. So magnesium, creatinine, these are basic workup. Magnesium is low.
It's very, very low. So we should know why this magnesium is low in this child, and we have to investigate this further.
So this was given intramuscular magnesium improved very well, but once we stopped intramuscular, his magnesium again went down and hypocalcemia. And then we got a genetic testing done, which showed that there was a problem in the magnesium transporter, which is there in the intestine and in the kidneys. So this child was losing magnesium from the gut and the kidneys. We had to give around 100 times the usual dose of magnesium. She is on magnesium sulfate, which has to be broken injection, and she drinks that at least 20 ml per day, and then her magnesium and calcium is fine. So hypomagnesemia is most common in malnutrition. So if you have refractory hypocalcemia, give magnesium, they will improve, but you can also have some genetic causes in that setting. 3-month-old girl with seizures, ionic calcium is 3.2, phosphorus is low, PTH is also low, diagnosed as hypoparathyroidism. Now, Dr. Vibha, do you agree with this?
Definitely not, sir, as we have hypocalcemia along with the hypophosphatemia. So when we have hypophosphatemia, the PTH level should be high. So in this case, the PTH level is low. So we should think about what is the transport is proper or not during the PTH transport, because PTH is a thermo level. So when it is left without the eyes, it will gone. So I think in this case, the cause of low PTH is the improper transport of the PTH, not the cause. It's due to hypoparathyroidism.
So you remember that anybody who has got hypocalcemia and hypophosphatemia, PTH is working. So how will you have low PTH? So this is something which is clear. So you are going more towards a vitamin D cause rather than a PTH cause here. So clearly in this scenario, vitamin D was very low. And as Dr. Vibha pointed out, somebody had sent to a collection center and they kept it there, the level will be low. So the message is PTH should be done in lab which are doing PTH, or directly they will transport in ice. That's a big message. Otherwise, you are wasting your money. So I talked about growth hormone basal being waste of money. PTH not done properly is also the same thing. So transport PTH on ice. If you have low phosphorus, exclude renal failure, exclude a parathyroid problem in that regards. 1 week old boy with seizures and low calcium. Phosphorus here is very, very high. Creatinine is normal. So now we have taken care of many things. And magnesium is also normal. So I think we have no doubt there. Most things are normal. So Dr. Rashmi, how will you now go ahead with this?
So since calcium, this child is having low calcium, but phosphorus is high. So we will go to the algorithm of high phosphorus. So this high creatinine was, phosphorus is high, but creatinine is normal. So we can think of these two things, either a pseudo-hypoparathyroidism or a hypoparathyroidism. So we do a PTH. So PTH levels were very low. So this case should be of hypoparathyroidism. And clearly, as the history says, there was seizure, and this is a DiGeorge syndrome. This child we saw, or both of us saw about a year ago.
So very early onset hypocalcemia, always think of some cause. Why does the child have hypoparathyroidism? And one of the common syndromic causes is DiGeorge syndrome. There you have cardiac defect, abnormal facies, cleft lip. This child had a very low level of TLC, and that was a clear-cut clue which was there. And these conditions are extremely difficult to manage, and they will have a lot of issues, but at least you should identify them at the right time and do a genetic study, and there will also be a cardiac defect.
So this child had come with repeated admissions for seizures at some other hospitals. He came, and every time he was diagnosed as hypocalcemia, but every time hypocalcemia was treated symptomatically, but the root cause was not treated.
So identifying the cause is very important, and you can easily have done it because his phosphorus was very high. So high phosphorus is equal to PTH problem, cardiac evaluation essential in hypoparathyroidism. 10-year-old boy with seizures, ionic calcium is 3.1, and this went to a neurologist. They got a CT scan done, and what they found here is that some funny calcium deposition is there. So do you think this requires the endocrine evaluation, Dr. Mahesh?
So in this child, with definitely seizures are explainable on the basis of hypocalcemia. So you need to try to find out the cause of hypocalcemia. And all of us know that hypocalcemia due to hypoparathyroidism or pseudohypoparathyroidism, both those can cause the calcification in the brain. But there is an associated clinical features that you also need to see. So if a child is having a depressed nasal breath, if there is a metacarpia, those are the few indications that probably suggest that this child may be having a pseudo-hypoparathyroidism. So accordingly, you can investigate further. So on investigation, if creatinine is normal, just like I said in the previous case, if creatinine is normal, then you need to go for the parathermone level. And if parathermone is low, just like in the previous, Dr. Rashmi talked about that particular case, this is hypoparathyroidism. If pH is on a higher side, just like in this particular case, the PTH is more than 200, so that is significantly very high. So most probably this is a child with pseudo-hypoparathyroidism.
So this child actually had cataract, he had brachymetacarpia, he had cutaneous calcification, high PTH. So this was clearly a case of pseudo-hypoparathyroidism. So we discussed a lot about hypocalcemia. We'll move towards rickets, which is a very common presentation. And we know that rickets basically means cupping and fraying, which is observed in this regards. And these radiological picture is important. Now, if you have rickets, the next step would be to give a course of vitamin D. The IAP has come up with guidelines which have shown that you should give a course of vitamin D, which is daily for 12 weeks or alternate day intermediate regimen. Also, they have mentioned about equivalent to that, or 60,000 international unit fortnightly. So the first step is when you have rickets, do not rush to do investigations. Give them a course of vitamin D. And if they are not responding, then only you start worry. You expect that with treatment, calcium may come down, bone pain may happen, alkaline phosphatase may actually increase, and the child may complain of increased bone pain. This does not mean that this child is not responding. This means actually the child may be responding. So if you are not giving calcium, they will develop hypocalcemia. And the only thing which is important is line of healing. So refractory rickets is one in which you have adequate treatment and lack of response. Other features like polyuria, seizures, fractures and growth failure, you start thinking of refractory rickets right at the diagnosis. However, you may have skeletal dysplasia which looks like rickets. You may have not given enough calcium, vitamin D, and then labeled as refractory rickets, or high ALP and bone pain was considered a marker of lack of response, which is not the case in that scenario. So if you have rickets, it could be because of deficiency, you give therapeutic response. If it's refractory, it could be because of a calcium problem where you have early onset, high PTH and low calcium, while if it could also be because of acidosis with urea failure to thrive and phosphopenic forms, which has late onset with lower limb involvement. So clinical parameters will give you a clue. The question is it rickets, is it refractory, and what's the cause? So if you have the initial workup, the most important test here again is phosphorus. What do you expect the phosphorus in a child with rickets? High or low? So phosphorus is the most important agent causing bone apoptosis and cause a problem. If you have phosphorus deficiency, you will have rickets. So if your phosphorus is high, this is renal failure or PHP. Otherwise, this is all because of a problem of nutritional deficiency. If urinary calcium is high, consider distal RTA. If PTH is normal, this is hypophosphatemic rickets. If alkaline phosphatase is normal, normally alkaline phosphatase should be very high. If it's normal, this is RTA or chronic kidney disease, and acidosis means RTA. So if you want to classify, the most important test is phosphorus. If your phosphorus is high, think of renal failure or PHP. If your calcium is low, think of vitamin D deficiency or renal failure. If your PTH is normal, this is hypophosphatemic rickets. And urinary calcium, if it is high, suggests RTA. So some basic workup, phosphorus, creatinine, urinary calcium will give you a diagnostic clue. And then, of course, blood gas will give you a clue. So the approach is, if your phosphorus is high, creatinine is high, this is CKD. If your phosphorus is low, go for renal tubular acidosis, hypophosphatemic rickets, and then finally you can go in terms of vitamin D dependent rickets. So phosphorus becomes very, very important. So next case, 3-year-old boy with rickets given 3 doses of vitamin D, now with bone pain, high alkaline phosphatase with a normal calcium, labeled as refractory rickets. Dr. Deepak, do you think this is refractory rickets?
No, sir. Actually, in the practice, it's happened that the parents thinks anything which say on treatment is refractory to the treatment, and even the unexperienced doctor in the initial stages, they do think like this. But as you have already said that during treatment for the kids, bone pain and alkaline phosphatase may actually increase it. That is actually good response to the treatment. Yeah. So for the response, that is not the actual thing to look for. We have to look for the line of on the X-ray. And we can clearly see there is beautiful line of healing on the X-ray. So this is not actually refractory, but rather sensitive, I can say, the case.
So don't go for biochemical parameters, go for an X-ray. If X-ray shows the line of healing, forget about it. If you diagnose refractory rickets, you have to do multiple investigations, which are not really required in most cases. So key messages are bone pain and ALP may increase with vitamin D, and line of healing is the best marker. We have a 4-year-old girl with rickets treated with the osteocal 5 ml twice a day with no improvement. And now they come to you with the X-ray showing no line of healing and refractory rickets. Dr. Vibha, what do you think is happening here? Is it refractory rickets?
No, sir, because before making a diagnosis of refractory ricket, we should be ensured that the treatment has been given for the adequate period of time, that is 12 weeks. But in this case, the treatment has been given for 30 days, and this 5 ml BD calcium is also not the optimum dose required for the vitamin deficiency.
So do you recommend the vitamin D separately or as part of, because many preparations have vitamin D in them?
No, sir, separately. That is the IAP guidelines have recommended a dose of 60,000 fortnightly for 5 doses and then monthly. And the daily dose of the calcium should be 50 to 75 milligram per kg per day.
So you should always give calcium along with vitamin D and then assess. So parental vitamin D should be given to whom?
So patients who have malabsorption like celiac disease.
Okay, so don't give IM calcitriol. Often we see orthopedician giving arachidol weekly and the child comes to us with hypercalcemia. Vitamin D is a safe drug, but if you don't use it properly, it will cause hypercalcemia, polyuria, constipation, and that becomes a big problem. So this is inadequate treatment, not an abnormality. 5-year-old girl with rickets, polyuria, weight is 10 kg, short girl. She has metabolic acidosis labeled as distal RTA. Now, Dr. Rashmi, do you agree with the diagnosis of distal RTA in this case?
See, immediately you cannot diagnose as distal RTA. You have to have some basic parameters like phosphorus, etc. So what was the phosphorus in this case? Phosphorus was clearly high, 9.9 milligrams. So I would like to know the value of creatinine. So clearly this is a case of renal disease, which is causing rickets in this child because of high phosphorus, high creatinine, low calcium. So this is the rickets because of the renal disease.
So this was clearly a glomerular disease rather than a tubular disease. So before you go ahead with rarer disorders, do simple tests. I think that is the key message we are giving. High phosphorus suggests that. 12-year-old girl with multiple fractures, failure to thrive, polyuria and myopathy. You can see severe bony deformities, losers zone, multiple fractures. Dr. Mahesh, could this be vitamin D deficiency?
Yes, whenever there is child comes with us with a multiple fracture, we always think about there is a first cause, maybe a vitamin D deficiency associated with malabsorption, or maybe the primary vitamin D deficiency. But usually, most of the time, the nutritional vitamin D deficiency not presented with fractures. There may be bony deformities that can be the presenting features, but the fractures are not the commonly the clinical features. Fractures, maybe you can consider the other differential diagnosis. There may be primary metabolic disorders, bony metabolic disorders, or secondary bony metabolic disorders. So we will definitely go on our protocol. So we will see the phosphorus that is 2.1. So that is on a lower side, and creatinine is 0.6. So if you will see that particular thing, and the next thing we will require is the blood gas. So on the blood gas, there is a 7.12 pH. So that is definitely showing most probably this child is having a metabolic acidosis. Though obviously we need more parameters to say it's hyperchloremic metabolic acidosis. And at the same time, if you do the electrolytes will be on a lower side, if potassium is on the lower side, we can think about this is a renal tubular acidosis. And you can confirm by doing the urinary calcium.
So she had calciuria and nephrocalcinosis, suggestive of distal RTA. The fracture in a child who really comes to you with rickets means a pathological cause. It is usually not a nutritional cause. You have to think RTA in that regards. 14-year-old boy with refractory rickets, Dr. Deepak, you can see this case. There is a lower limb involvement, which is there predominantly. There are a lot of bony issues which are happening there, bone resorption. What do you think is happening here?
Sir, as we can see, this having rickets and predominantly lower limb involvement, that too in a 14-year child. So clearly indicates this is probably not nutritional, and we have to think beyond nutritional rickets. And in a male child, most probably looks like hypophosphatemic rickets. So can we have biochemical parameters?
Yeah, so biochemical history shows the phosphorus level, which is low. There is no metabolic acidosis here. So we are now going into the algorithm towards this area. And calcium and PTH is also normal.
So in this child, we can clearly see the phosphate is normal, calcium is normal, and parathyroid level is probably normal. So this is most likely hypophosphatemic rickets, and we have to treat with phosphates. And recently we have monoclonal antibody too.
So if you have a late onset lower limb abnormality, that is hypophosphatemic rickets. And here calcium and PTH level will give you a clue. We'll touch base briefly about hypercalcemia, which is rare but important to identify. If you have a sick neonate with dehydration, polyuria, hypotonia, encephalopathy, get a calcium done. So when you have electrolyte, also get a level of calcium done. Hypercalcemia, which may be there. So you need to be careful in terms of evaluation in that regards. So calcemia, as I said, with multiple abnormalities. And if you think of hypercalcemia, the most common cause in children, I would say you will see is vitamin D excess. The most common cause is somebody has prescribed vitamin D. The parents are giving for multiple time. They will come to you with polyuria, constipation, irritability, dehydration. If you not measure their calcium, you will miss it. I have seen cases who became very sick, requiring ICU admission for hydration, diuretics, and steroids. So always, if you have a child with irritability, failure, ask whether they are giving too much vitamin D and get a calcium done in that regards. Hyperparathyroidism is rare, but this is a very important thing in that regard. Again, PTH related causes, your phosphorus will be low. Vitamin D related causes, your phosphorus will be high in that regards. And PTH will give you a clue in that regards. So PTH should be interpreted in the light of calcium. Anybody with a high calcium should have a low PTH. If you have a detectable PTH with a high calcium, this suggests that there is a hyperparathyroidism in that regards. So if PTH is below 20, this is vitamin D related, vitamin D excess, or some other disorders which are there. If you have a PTH which is high, then you have to think of hyperparathyroidism and an endocrine referral is required. So a 12-day-old girl with irritability, dehydration, calcium of 18. So the first good thing is that the calcium was done. Otherwise, often calcium is not assessed in this setting. Dr. Vibha, what do you think in this case?
So definitely the child has hypocalcemia along with the symptoms of hypocalcemia like dehydration and the irritability. So if we go according to the algorithm, after the calcium level, we need to go for the PTH level, whether it is high or low. So in this case, PTH level is 120, which is quite high. Then after the PTH level, we should go for the urinary calcium creatinine ratio, whether it is high or low. And in this case, the urinary calcium creatinine ratio is low, which is 0.3. So this is going towards the calcium sensing receptor defect. And if the patient present at this very young age, so it is a neonatal severe hypoparathyroidism in this case.
So if you have a neonate with very high calcium levels, it is most likely a life-threatening condition. It requires immediate stabilization and would require a parathyroid surgery. Otherwise, the child will not. We had a very good case presented yesterday. So clearly, polyuria and dehydration, think of calcemia. 2-year-old girl with abdominal pain, ultrasound showed nephrocalcinosis. This was unusual. But then when we did a calcium, it was 13.6. Phosphorus was high. So high phosphorus, as I said, excludes a PTH cause. Now, Dr. Rashmi, what do you think could have gone wrong in this child?
So we will again go to the algorithm. So here PTH was, what did you say? PTH was
Undetectable. Yeah.
Undetectable. So since we know high calcium PTH is undetectable and there is low 25 hydroxy vitamin D. So
vitamin D was very high
yeah.
actually. So when we did vitamin D, it was 200. Below.
So yeah, 20. So it was very high. So this clearly means that people must give in extra doses of vitamin D, and that's the reason for excess of vitamin D.
So this is clearly an exogenous steroid use. Remember that PTH has a conservatory effect in calcium excretion. So if you have same level of calcium because of hyperparathyroidism, urinary calcium will not be that high. But if it is because of vitamin D, your urinary calcium will be very high. Develop nephrocalcinosis immediately. So this is vitamin D toxicity. What will you suggest in this case, Dr. Rashmi?
So in this case, we will suggest, of course, if this is vitamin D toxicity and what are the symptoms of the child, because this child may have severe headache and this child may land up in coma also.
Yes.
So we would like to admit the child, and steroids are the mainstay of treatment and good hydration should be given. So many a time children need PICU admission.
So anybody whose calcium is above 13 should ideally be admitted, give a good amount of fluid, give diuretics and start steroids. Steroids will be required for 2 to 6 weeks. Ask them to avoid milk and other dairy products during that time. Closely monitor their calcium. So this could be a life-threatening disorder actually. And we have seen many cases because of vitamin D toxicity in that scenario. 15-day-old girl with preterm, 28-week gestation with hypercalcemia. Phosphorus is on the lower side. PTH is undetectable. Dr. Mahesh, what is going wrong here?
So this side is actually a 15-day-old girl admitted in 28 weekers, most probably admitted in NICU. Our phosphate is definitely on a very lower side, and PTH is less than 1. So as you said already, that doesn't look like to be a PTH related cause. So PTH related cause probably is out in that scenario. So when we go with this algorithm, we will find out this may be a vitamin D related cause. So vitamin D 25 OSD is on a lower side and calcitriol is on a higher side. So you can say and phosphorus is on a lower side. So whenever there is a low phosphorus, it usually increase the 25 hydroxylase. So that will result in more production of calcitriol, and that will result in ultimately the hypercalcemia. So it looks like to be more of an TPN related, where probably the low phosphorus was given in the setting, and that resulted in hypercalcemia.
So in TPN, if you give too much phosphorus, you will have hypocalcemia. Too little phosphorus will cause hypercalcemia. So this is very, very important to give the right dose of phosphorus. 4-day-old boy with seizures, birth weight 3.2 kgs, asphyxia. Calcium is 18, extremely high. Phosphorus is 4.2, PTH is 0. Dr. Deepak, what are we looking at?
So as we can analyze from this case history, this hypercalcemia doesn't look like to be parathyroid related. There is something more. And in this case, like asphyxia, we have to look for particularly subcutaneous nodule if there is something like fat necrosis or like that. So can we examine this child? So you can clearly see there is some palpable nodule. So this is a fat necrosis case probably. And we can see the calcitriol is way, way beyond the normal limit. So probably our diagnosis is correct. This child is having automatic conversion from the 25 hydroxy vitamin D to calcitriol, and this can clearly lead to severe hypercalcemia, life-threatening. So it's good that the pediatrician has done all this wonderful workup. So the treatment will require good hydration, diuretics, and steroid for a few weeks.
So one clue, if you have hypercalcemic child, feel for the skin. If there are very firm violet colored nodules and a history of birth asphyxia, this may be the first sign that this is actually a fat necrosis. And we had a very good case with Dr. Arpita presented yesterday. And in that scenario, this fat necrosis area, you have got a lot of granulomatous tissue coming up, and that's converting a lot of 1-alpha hydroxylase, converting it into calcitriol, causing hypercalcemia. Again, a course of steroid is required in that regards. So at this point of time, we are able to finish off the calcium module at a very reasonably brisk stage. I think it was hopefully clear. So if there are any questions from the audience, we will like to have them. So any questions? Dr. Ambrish? Okay. Yeah. Yeah.
Preferred you,
Okay.
but he must be coming sometime.
Yeah.
I just want to ask every child you with multiple fractures, you think the renal rickets?
Yes. So if you have multiple fractures, the first thing is to look at whether there is a primary bone problem or a outside problem. So primary bone problem will be osteogenesis imperfecta. So usually osteogenesis imperfecta will be much earlier onset. One clue of milder form is sclera. So look for their eyes. If they have a blue colored sclera, that could be osteogenesis imperfecta. Diagnosing OI is very, very helpful because we can give them bisphosphonates, which really improves them in terms of reducing fracture rate and very, very effective in therapy. So first I'll ask for family history, sclera and other things. RTA typically, they will present more with also failure to thrive. They will have polyuria, hypocalcemia. They will be looking sick. But yes, that is important to look at. Blood gas will become important, but that will depend upon the clinical picture.
At the first go, the child very nicely improved. He started walking, everything.
It's
But
very unusual for nutritional rickets to cause fracture. Actually, this is a recommendation that if you have nutritional rickets, you will not have fracture. If you have fracture, you at least evaluate for RTA.
Actually, surprisingly, he improved. I didn't expect that he will improve. That's why I'm asking you.
It's unusual, but
Yeah.
rarely we can
It's
happen
unusual,
in
yes.
that regard. I just look camera. Okay, so I like to thank all the panelists, Dr. Rashmi, Dr. Mahesh, Dr. Deepak, and Dr. Vibha for joining us, and it was a wonderful session. I'll hand over. Yeah. Yes, so we have a we like request Dr. Alapan to felicitate Dr. Mahesh with a memento. And Dr. Deepak as well. So we will be moving towards the next session, requesting Dr. Dhwani to invite the panelists for the session.
We've come to the end of this 2 days long journey. And for the last session, I would like to invite Dr. Pradeep Kumar, who is a professor in pediatrics at AIIMS Patna, Dr. Jyoti Agrawal, who has joined us from Nepal, Dr. Nitin Pandey, who is a practicing pediatrician from Lucknow, and Dr. Tarun Chandra, who is an intensivist at Regency Healthcare.
This is going to be a session on electrolytes, and electrolytes often is some situation where everybody gets confused. And there are some people who hate electrolytes and some people who hate it badly. So I've hardly met somebody who really likes electrolytes in that regard. So we'll try to cover some important aspects of electrolytes. You need to understand a bit about homeostasis. So when you talk about the level of sodium in the body, you have to look at the tonicity and the volume. So sodium level will not only depend upon its own level, it will also depend upon the water level. So if you have hyponatremia, it may be because of little sodium or more water. What is more important, water or sodium? It's actually the free water. Most hyponatremia is because of a high level of free water. Now, water is conserved using two mechanisms, thirst and urine. So thirst, how much water you drink, and how much you excrete. These are the two parameters which really decide from that perspective. And from the brain, you have got the organum vasculosum, lamina terminalis, and subfornicular organ which control that. And they secrete a very important hormone called arginine vasopressin, which basically is responsible for the retention of water. So if you're getting dehydrated, vasopressin will come up and it will conserve your water coming from the urine. And your volume goes down, the renin, angiotensin, aldosterone system gets activated. And this system basically causes increased loss of potassium. So if you have RAS excess, you will have hypokalemia. If you have RAS deficiency, you will have hyponatremia with hyperkalemia. Now there is a third player, which is atrial natriuretic peptide, which is causing the loss of sodium in that regard. So this becomes very, very important. And potassium, as we know, is largely an intracellular ion, which is regulated from that perspective. If you give somebody a beta agonist, you will cause pushing of the potassium inside. Serum sodium can be done any time of the day, but remember that do not do it after strenuous exercise. You may have falsely high level of sodium. After a seizure also, the sodium levels may be high. You may have falsely low level in the setting of deficiency of protein, lipids, and glucose excess, and high levels in hypoalbuminemia. Normal range is 135 to 145. We are worried about levels less than 130 and above 150. Potassium should be done any time of the day. The caution is avoid hemolysis and syringe, no tourniquet or standing sample. Levels may be falsely high in hemolysis. So I said phosphorus, potassium, magnesium, do not use tourniquet, and low with high counts, the levels may be low. For blood gas analyzer, the value is typically down by around 0.4. So again, take it with a pinch of salt in that regards. Very importantly, there is a close interplay between sodium and potassium. If your sodium is high, generally potassium is low. If your sodium is low, your potassium is high. So high sodium, low potassium means excess of the renin, angiotensin, aldosterone system. If you have hyponatremia and hyperkalemia is a problem in the renin, angiotensin, aldosterone system. But what about condition of high sodium and high potassium? Anybody? That means you are retaining both sodium and potassium. The classical example is Gordon syndrome. On the other hand, if you have low sodium and low potassium, it means you're losing both either in the intestine or using the kidney. So Bartter, Gitelman, tubulopathy, diuretic use, that is the classical cause of hyponatremia with hypokalemia. So hypokalemia is the most important, so we'll talk that. It can be because of excess free water, which will be U, or hypervolemic with low levels of uric acid, or a sodium loss where you're losing sodium, where you will lose volume. You will be hypovolemic with high uric acid. Excess free water can be overload, cardiac, liver, or renal. Here, your urinary sodium should be less than 25. Anybody with hyponatremia should have a urinary sodium less than 25. High urinary sodium means a urinary loss. While if your free water loss is reduced because of SIADH, cortisol deficiency, or hypothyroidism, it may be there. Remember, SIADH is a diagnosis of exclusion. Always look for cortisol deficiency and hypothyroidism. Sodium loss can be extra-renal, where your urinary loss will be less, or renal, where your urinary loss will be more because of a tubular problem or a RAST effect. And here the urinary sodium will give you a clue. So the most important test to look at is uric acid. Uric acid is a marker of fluid status. High volume, high urinary loss of uric acid, low uric acid. High uric acid means that you have got volume depletion. Urinary sodium, as I said, if it's more than 25, it really indicates that you're losing sodium in the urine. And if potassium is high, hyponatremia with hyperkalemia means salt wasting in that scenario. So the approach is look at volume, too much volume, fluid overload. If volume is normal, get a thyroid cortisol normal, this is SIADH. If it's hypovolemia with a low urinary sodium, it is GI loss. High sodium, you look at potassium to classify into tubulopathy or RAST effect. So again, very basic things, volume, urine sodium, and potassium. I'm not talking about any very costly investigation like renin or aldosterone at the moment. These will give you a clue. So we'll start off with the cases, please, Dr. Dhwani.
Thank you, sir. And the first case that we have here is a 12-year-old boy with diabetic ketoacidosis. He has high sugars with hyponatremia, normal potassium, and a metabolic acidosis. So my question is to Pradeep, sir. Do you think we need to do something for this hyponatremia or
Okay, so as we have went through the review of hyponatremia, what we have seen, whenever you have sodium, always relate it with sugar, potassium, this protein, lipids, etc. What we see here, this is a patient of DKA where there is sugar very, very high. So we have to convert and we have to see the corrected sodium. What is the value of corrected sodium? So generally, okay. So generally what we do, we calculate with this common formula, sodium plus blood sugar minus 100 into 1.6 upon 100 into 1.6. Commonly we use 1.8 for every 100 milligram of sugar which is raised. So applying that, it will come approximately 136 milliequivalent per liter. Which is normal for this patient. So this is clearly a case of pseudo hyponatremia.
Thank you, sir. So as rightly pointed out, hyperglycemia can falsely decrease your serum sodium levels, and you need to correct it to get the right sodium value. If your corrected sodium is in the normal range, you need not intervene in such patients. The second case is a 1-week-old child who was brought with complaints of lethargy and was found to have hyponatremia with normal potassium. So I would like to ask Jyoti ma'am, how would you like to approach this child?
First of all, we have to see if there is dehydration or not, because there is hyponatremia with normal potassium level. So what is the hydration status of the child?
The hydration status was normal in this child.
So seeing on to the algorithm, fluid status when there is euvolemia. So we have to see for the blood sugar levels, we have to see for the thyroid and the cortisol level.
Now that we see that the child has a ketotic hypoglycemia, what diagnosis do you have in mind of a child with ketotic hypoglycemia and hyponatremia? What finding, if this was a boy, on clinical examination would point to the diagnosis here?
So we have to see for the micropenis and other midline defect to come to the diagnosis.
So very well pointed out by ma'am. Euvolemic child with mild hyponatremia and a ketotic hypoglycemia points towards a cortisol deficiency. And as we know, in a euvolemic child, you think of SIADH, but it is a diagnosis of exclusion. So before you jump to that conclusion, you carefully examine the child. And this micropenis points towards the pathology of MPHD, multiple pituitary hormone deficiency, wherein the child will have hyponatremia and ketotic hypoglycemia. So in this child, during hypoglycemia, cortisol and growth hormone levels were done, which were subpar for the level of hypoglycemia. Moving on, the next case is a 14-year-old boy who presented with drowsiness and a more severe degree of hyponatremia, that is 116 millimoles per liter. Clinically, he is euvolemic, has urinary sodium of 100, urinary osmolality of 300. So dilute blood, concentrated urine, the diagnosis of SIDH was considered and the child, fluid restriction was done for the child. Do you agree with this diagnosis, sir?
Actually, the picture is looking like a side ADH only, but as you already told that it is diagnosis of exclusion. So first, because it is euvolemia, we will first see cortisol and thyroid level, and if they are normal, then we'll diagnose SIADH. So as we see in the values, thyroid is low, free T4 is 2, which is low, cortisol is also low for this 120. So it is the we will diagnose it as multiple pituitary hormone deficiency, not SIADH.
Very well pointed out. So if in the setting of hyponatremia, when your sodium is 116, your cortisol should be more than 550. If in that setting, your cortisol is less than 550, you need to think of an underlying cortisol deficiency. And when you have a isolated cortisol deficiency is usually unlikely. So in that setting, you can also look for other pituitary hormone involvement. Like we see here that thyroid levels were also low. So we have an algorithm that we've developed for evaluation of children with hyponatremia, and you can definitely check out our app and use it in your clinical practice. Next is a 3-week-old child with failure to thrive. Again, very low sodium, 110 millimoles per liter. Had a birth weight of 2,500 grams and at 3 weeks has gained only 100 grams. The neonate is clinically dehydrated with a PCV of 62, has elevated urine sodium of 100 millimoles per liter. The catch here is the child has a serum potassium level of 8.4. So my question is to Dr. Tarun sir, what all differentials would you consider in a 3-week-old neonate coming with hyponatremia, hyperkalemia, and an increased urinary sodium?
So it is a clear case of we will go for the fluid status, as well as we know that the child has only gained 100 gram since 3 weeks. So it is clearly evident in PCV also the child is dehydrated. So my next step here will be to looking at the urinary sodium, which is clearly more than 30 millimoles per liter in this child, which is 100 millimoles. And then we go for the potassium in this. If potassium is low, we have a single reason of tubulopathies or the use of external drugs like diuretics or other things. But here the high potassium indicates either it is a RAS defect or aldosterone deficiencies, as well as this is a picture of genitalia of the child.
Yes.
So it is a DSD with bifid scrotum, I think, and with empty testis, no testis there, and probably the clitoral hypertrophy. So this is a congenital adrenal hyperplasia. So the most common which presents with at an early age of this 3 weeks, so could be a 21 OSD defect. So in this cases, high 17 OHP levels clearly indicate this is a CH.
Very rightly pointed out, sir. So in around 3 to 4 weeks, if you have a baby coming to you with hyponatremia, hyperkalemia, appears dehydrated, look at the genitalia. If it's a female, if it's actually an XX karyotype, you will see empty scrotal sacs with clitoromegaly, or which may also appear male genital-like. However, if it is a male, it is often missed out because the genital may be normal. But if you have hyponatremia, hyperkalemia in a 3 to 4 week child coming with dehydration, think of CAH, get 17 OHP levels done, which may help you clinch the diagnosis in such patients. So as sir has rightly pointed out, 17 OHP levels were high, and this was actually an XX DSD presenting with salt wasting crisis. Next, we have a 6-month-old girl who was diagnosed with cystic fibrosis in view of the fact that she had failure to thrive and had recurrent chest infections. She also had high sweat chloride levels, and on the basis of which she was treated on the lines of cystic fibrosis. However, she had no steatorrhea, suggesting that there was no exocrine pancreatic insufficiency. When she came to us, she presented with a salt wasting crisis, and what we found on evaluation was hyponatremia and hyperkalemia. So I would like to ask Dr. Pradeep, do you agree with the presence of hyponatremia with hyperkalemia in a child with cystic fibrosis, or should we consider an alternate diagnosis here?
Okay, so in this infant, we clearly see that in spite of having recurrent chest infection and high sweat chloride, but there is no signs of exocrine failure in terms of no steatorrhea, and there is hyponatremia and hyperkalemia. So naturally, for the algorithm of hyponatremia, we should know the next, what is the volume status of the patient. So volume is, I think, dehydrated. So next we have to see what is the urinary sodium excretion, and then potassium, serum potassium. So urinary sodium excretion is, I think it is more. So we should consider
Yeah, so
yes,
the child is losing salt in
salt.
Yes, so this is hyponatremia.
Hyponatremia.
The baby is losing salt in urine despite having hyponatremia and has very high renin and aldosterone levels despite hyponatremia.
So yes, so normally there should have been this. We should have considered RAS defect, but what we are seeing here, the both are high. So resistant should be maybe the resistant of this tubular receptors resistant can be there. So we can go for further, yes. So ENaC, epithelial sodium channel receptor resistance might be there, which can present as pseudo hypoaldosteronism type 1.
Yes, sir. Thank you. Very well pointed out.
So I think a very important message, if you have hyponatremia and hyperkalemia, that is a very, very lethal combination. This child will go into crisis, may die also. So if you have hyponatremia and hyperkalemia, immediate evaluation and management is required. Most common cause is 21-hydroxylase deficiency. Look at genitalia. If it's abnormal, you get the diagnosis. But remember, males may have no clinical features. So you may miss the diagnosis there. And then if you have excluded that, then go for pseudo-hypoaldosteronism. They are often misdiagnosed as cystic fibrosis. Why, Dhwani?
Because the clinical presentation is very similar. They are hypovolemic. Their chest secretions are stickier. So,
and I remember this girl was admitted in the ICU a couple of times because they develop a lot of inspissated secretion and they become really pneumonia and become very, very difficult. Even mild infections become severe in these scenarios. Tarun had managed this girl a couple of times in the ICU. So this is an important scenario to look at. But we expect, what will be the potassium in cystic fibrosis?
Cystic fibrosis will classically have hyponatremia, hypokalemia, hypochloremia, all low.
So this will be really against this scenario.
Sorry. Moving on, we have a 1-month-old child who was brought with complaints of reduced feeding, had a birth weight of 3,100 grams and now only weighs 3,200 grams. So that's poor weight gain. Has hyponatremia with hyperkalemia. The first diagnosis that we thought of was CAH. So we went ahead with 17 OHP levels. However, the levels were normal, but the cortisol levels that were done showed elevated 1,200 nanomoles per liter, which is an appropriate response in the setting of hyponatremia. The next, we went ahead with renin aldosterone levels, and they were both again on the elevated levels. So my question is to Jyoti ma'am. Now, this child appears very similar to what Pradeep sir's case was. So, but however, this baby does not have any chest infections so far. So what will you think of the diagnosis in a neonate presenting with such complaints?
So 1-month-old boy presenting with failure to thrive, with hyponatremia, with hyperkalemia. First, we have to rule out 21-hydroxylase deficiency, CAH we have to see. Since 17 OHP is normal, then we have to see for the cortisol axis, that is normal. It's normal response to the hyponatremia. Then we have to see for the renin aldosterone. We have to see for the aldosterone axis. So aldosterone is 200 nanogram per deciliter. In such case, we have to see for the transient pseudo hypoaldosteronism. So in that case, we have to see for if there is the urine REME, and we have to go for the renal imaging to differentiate it from other hypoaldosteronism. So in this, so what is the urine REME and
Yes, so ma'am, as you rightly pointed out, the urine routine showed evidence of infection with more than 100 pus cells.
and we have to go for the USC where, okay, there is
Sure.
obstruction. So this is the case of transient hypoaldosteronism.
Yes, thank you so much, ma'am. So again, as ma'am very well pointed out, so in a child, 1 month old neonate presenting to you with hyponatremia, hyperkalemia, you will always want to rule out CAH. When you get normal 17 OHP levels with high cortisol, you know that the glucocorticoid axis is preserved. So we went ahead with to look at the mineralocorticoid axis. Now we see that both aldosterone and plasma renin levels are elevated. So this scenario is very similar to the previous case where we have an aldosterone resistance. However, before we think of a genetic diagnosis, especially in a neonate, we need to rule out a CACT abnormality or a urinary tract infection before we label these children as hypoaldosteronism, because in these children, the pseudo-hypoaldosteronism will be transient and they will recover with treatment of infection. Over to sir.
Based upon your sodium level and the duration, and this is very, very important because you can have a lot of problems if you treat it inappropriately. So the duration is less than 48 hours, which is acute hyponatremia, and there are symptoms like seizures and sodium is very low, then you give 3% saline, which will be there to correct the sodium level in this perspective. If, however, you have mild to moderate symptoms, 120 to 130 with symptoms, you can then give a small dose of sodium chloride. Do not give high doses of hypertonic saline because that can cause cerebral problems and that can be really difficult. If it's above 48 hours, go for symptoms, and symptoms are severe, you can give a course of 3% saline. If they are mild symptoms, don't give 3% saline. This is a big message that do not give 3% saline in the absence of acute symptomatic hyponatremia. Otherwise, the child is going to have a lot of problems and they will go into a brain injury. So hyponatremic dehydration, we correct based upon dehydration level. We look at how much is the sodium deficit, how much is the isotonic sodium deficit, what is the maintenance requirement, what is the correction dose, and how much fluid has been received, and then we calculate that. Usually, you will be able to have a good enough volume, and this is calculations already provided, and we have developed applications to identify. In general, you don't want a very, very high level of sodium. You will maybe have a normal saline or a half normal, which will do the trick. So in this case, it turned out to be 90 millimole sodium at 65 ml per hour. Coming on to the second scenario of hypernatremia, it can be because of reduced free water, which is because of decreased intake, but mostly because of increased loss, because of extrarenal or renal problems like diabetes insipidus. So hypernatremia chronic can be because of diabetes insipidus or a sodium load, which can be endogenous or exogenous. Most common cause, as I said, is because of a free water problem and not because of a sodium overload. So if you have a child with hypernatremia, look at salt load, mannitol, and diabetes. If it's not there, go for urinary osmolality less than 600. This is diabetes insipidus. Check for vasopressin response. Present central DI. Absent, it is nephrogenic DI. If on the other hand, urinary osmolality is high, concentrated blood, concentrated urine, look at urinary sodium. If it's less than 25, this is GI loss. More than 25, this is sodium load. So we'll start with the first case, 3-month-old girl with altered sensorium. And Dr. Dhwani.
Thank you, sir. So we have a 3-month-old girl with altered sensorium, has a sodium of 170 with normal potassium. The urine osmolality is 100 milliosmoles per kg. And this child was, because in view of concentrated blood and dilute urine, was advised water deprivation test. So my question is to Dr. Nitin, sir, do you agree with this step?
Actually, for diagnosis of diabetes insipidus, this is the gold standard test. But when diagnostic criteria is already met, so we don't have to do this test. As the criteria is that if sodium is more than 145 and urine osmolality is less than 600. then it is diagnostic of diabetes insipidus. So we'll directly give the vasopressin to see it is central or nephrogenic.
Absolutely, sir. And in fact, doing a water deprivation resulted in precipitation of seizures and did more harm. And so in such scenarios, as sir has mentioned, where you meet the clinical criteria, you can go ahead with the AVP response test directly.
Yeah. And response was positive, so it is central. Okay.
Next, we have a 14-day-old girl with failure to thrive. The birth weight was 2,600 grams and now she weighs 2,300 grams. She was exclusively breastfed by a primary gravida mother and her serum sodium was found to be 182 millimoles per liter with extremely high urine osmolarity of 1,000 milliosmoles per kg. So my question is to Dr. Tarun. How do we explain this condition? If we are losing sodium in urine, why is it still high? What is going wrong with this child?
So this is a failure to thrive, not gaining weight, exclusively breastfed, high sodium, high urine osmolality. So probably some external sodium load is being given to the child. So we look for urinary sodium in this patient. So if urinary sodium is more than 30 or less than 30, if more than 30, that means it's a clear sodium load. And with a high urinary sodium in this child of 110 millimoles and urine osmolality of very high. So probably this is a primary gravida mother, which is a lethal condition in newborns in which breast milk related hypernatremia is there, in which due to decreased amount of intake of the breast milk as well as the decreased production of the milk breast milk, the child intake is low and the child gets severely dehydrated. In these kids, we don't assess the dehydration level because the skin is doughy to touch and the child is not so lethargic because of hypernatremia, a good vascular volume in the kids. So probably it's a breast milk related hypernatremia.
Yes, very well pointed out. So, especially in the setting of a primary gravida mother, if there is difficulty in feeding or an inadequate expression of breast milk, the babies develop hypernatremia due to reduced fluid intake and not per se because of an increased sodium load. Next, we have a 13-year-old boy with encephalitis. The child is on ventilator and suddenly has developed polyuria at 10 ml per kg per hour. So I'd like to ask Pradeep sir, what will you think of in this condition? What is the first test you would like to order here?
Okay, so definitely this patient is a patient of CNS infection and already on ventilator and there is polyuria. First, we have to see whether what is the sodium status of the patient. So it is very high. Sodium is high and urinary osmolality is low. So definitely it is meeting the criteria of DI. And since we have already the diagnosis central means CNS infection, we would definitely think about central DI. And post AVP response is also there. So it is central DI. And
what made the central DI develop out of nowhere in a child with encephalitis, sir?
yes, yes. So it is central DI is common in all CNS infections. But here
there's also clinical deterioration. The GCS has become E1, M1, V1, which was previously responding.
Okay, okay. So brain death may be one of the cause, but otherwise also DI is quite common in this setting.
So if you have DI in a sick child, basically the main message is that the hypothalamic AVP neurons are very widespread. It means that a big area of your hypothalamus is gone. So if you have a sick child who suddenly worsens and develops diabetes insipidus, that's brain death. Generally, we talk about that. However, as very nicely said by Dr. Pradeep, that if you have infections, you can have both SIADH, salt wasting and DI, all things can happen. But this scenario of a reasonably okay child suddenly becoming bad and pouring lots of urine, this is a form of a brain death DI. And in this case, do not give too much of vasopressin. Better is to give them fluid management will be better.
I'd like to invite sir again for the acute management of hypernatremia.
So now if we talk about the acute management of hypernatremia, again, it will depend upon what is the duration. So you want to correct it over at least 48 hours. Don't be in a hurry. Start maintenance fluid at the usual 4-to-1 equation. Then add free water deficit and ongoing loss. This is what you want to look at. The target fall is 9 to 12 millimole per liter. Do not want a dramatic fall in sodium because that can cause problem. In chronic cases, you can have a fall of around 6 to 9 because too rapid rise is bad in hyponatremia. Too rapid fall is bad in hypernatremia as well. The protocol is you typically give sodium of 70 to 100, 120% maintenance. You'll usually get the trick. Monitor very closely for sodium 4 hourly. GCS status, you expect seizures to happen. Always have 3% saline ready. If you have a sudden decline in sodium and seizure happens, give a 3% saline. Similarly, if you are treating hyponatremia and the child becomes unwell, that is pontile myelolysis is happening, give them free water. So that's the opposite. Both of these things should be ready in that perspective. So hypernatremic dehydration, you look at the fluid deficit, free water deficit, isotonic dehydration, how much maintenance is to be given, and correction, and you will get a clue about what sort of fluid you want to give. In that regard, always be ready for seizures which may happen in that regard. And there are equations you can get this from the various parts, and you can get how much sodium and how much fluid is given. If you give N/2 and above, over a 48 hours, you are okay from that regards. Finally, about hypokalemia. Hypokalemia can be because of cellular shift. All the potassium is going into the cell because of the insulin or other factors, or you are losing extra renal. In these scenarios, your potassium in the urine will be less than 20. You may have urinary loss where your urinary potassium is high. This could be either RAS dependent with hypertension because of hyperaldosteronism, Liddle syndrome, 11-hydroxylase, 17-hydroxylase, or you can have a problem of RAS independent cause like tubulopathy or RTA. Tubulopathy, you will have alkalosis. RTA, you will have acidosis. So looking at the volume status, looking at the blood pressure, looking at your pH status, you will know which way you are going for in terms of these problems and the scenarios. So clearly, if you have a volume, which is very, very important, you expect hypovolemia. If you have hypervolemia with hypokalemia, this is RAS excess. Urinary chloride and pH are very important. Everybody with hypokalemia should have alkalosis. If you have hypokalemia with acidosis, you have RTA or diarrhea. And again, magnesium is very important. We all say refractory hypocalcemia, get a magnesium done. But if you have refractory hypokalemia, there also magnesium becomes important in that regards. And then, of course, you can have a look at the blood pressure also, which will give you a clue. So any patient with chronic hyponatremia, exclude diarrhea, diuretic use or malnutrition. Blood gas, if it shows acidosis, do a urinary anion gap. If it is positive, it is renal tubular acidosis. Negative is GI loss. If you have alkalosis, this is a more common phenomena, and you have hypertension, you look at urinary calcium to identify Bartter syndrome. And if you have low urinary calcium, it is Gentleman syndrome. Hypertension with hypokalemic alkalosis is high aldosterone. And if aldosterone is high, it is hyperaldosteronism or CAH variant, or you have rarer causes. So mostly you will be seeing hypokalemia with acidosis, RTA versus GI loss, or this hypomagnesemia, which will be an important parameter to look at. So looking at basic things, you will make a diagnosis. So over to you, Dhwani.
Thank you, sir. We have a 2-month-old boy with hypokalemia in the setting of metabolic acidosis with a normal anion gap. How do we differentiate between diarrhea and RTA, Dr. Jyoti ma'am?
So 2-month-old boy with metabolic acidosis with normal anion gap, there are two main differential. One is GI loss and second is RTA. Now we'll see for the urinary. Yes.
Yeah.
Okay.
So urinary electrolytes.
Now we'll see for the urinary anion gap. If it's less than -20, it's GI loss. If it is more, if it is +20, it will be RTA.
So as we can see here that the sodium and potassium levels, even if combined, are less than the chloride level. So this is a negative.
It will come negative. So this is the case of diarrhea.
Very well pointed out, ma'am. So if you normal anion gap metabolic acidosis with hypokalemia, the two major differentials are RTA and diarrhea. To differentiate between the two, because both these conditions can present with the child having actual diarrhea. So to differentiate between the two, look at the urine anion gap, and if it is negative, you think of a GI loss, and if it's positive, you think of a renal tubular acidosis. Moving on, we have a 3-month-old girl with failure to thrive with hypokalemia. Had a birth weight of 2,800 grams and now at 3 months has gained only 700 grams. Contrary to the previous case, this child has a metabolic alkalosis in the setting of hypokalemia with BPs on the low normal side. So my question is to Dr. Nitin sir, how do we go forward in this case?
So the case is showing that the baby has failure to thrive, hypokalemia, alkalosis, and BP normal or little normal to low.
Yes.
So we will proceed with the two diagnoses, either Barta or Zitterman. For that, you will do urinary calcium. And if it is high, then the diagnosis will be Barta if it is high. And in the low, the baby age is very low. So Barter is more common.
Thank you, sir. So again, hypokalemia with metabolic acidosis, you think of a mineralocorticoid action excess probably. But in that setting, your BP should have been normal or high. Now that you see BPs on the low normal side, you think of, as sir has pointed out, Barta and Gentleman here. And to differentiate between the two, your urine calcium levels will guide you. Nephrocalcinosis is a surrogate marker of high urinary calcium levels, and this was a child with Barta syndrome. Next, we have an 8-year-old boy with early puberty, height of 134 centimeters, which is advanced for an 8-year-old boy. Had a pubic hair stage 4, which is quite advanced. The blood gas analysis revealed hypokalemic metabolic alkalosis with urine chloride of 100 millimoles per liter and BP on the higher side for an 8-year-old child. So my question is to Dr. Tarun. What differentials are you thinking of and what would you like to look for on clinical examination in this child?
So as evident from the scenario, it is a precocious puberty with metabolic alkalosis, with hypokalemia, with hypertension. So I would like to look into two differentials like Rast effect or some steroidogenic hormonal defects like DOC or 11 DOC. And in this child, the cryptorchidism is there. So
if we go by the pathway, it says that if your blood gas shows alkalosis and your blood pressure is high, you look at the aldosterone level. But we have a high BP, which is a surrogate marker that aldosterone level
levels are high. So
you've got undescended testis and yet precocious puberty.
Precocious puberty.
So that means testosterone is not coming from the testis. It is coming from some other organ. That would be the adrenals. So this is not actually a XY individual. This is an XXX individual with severe virilization, as you were suggesting, on 11-hydroxylase deficiency. So XX with adrenal producing a lot of DOC causing hypertension, hypokalemia, and then we also have a DSD in that regards. So I think with that, we come to the end of this session. Just to make a few announcements, we have got a postgraduate lecture series, which happens every month, which we basically have till now, I think, done 20 lectures. And we plan to do 36 lectures in over 1 hour period. It's also available on YouTube. Very, very useful for postgraduates to go through. It has got all these algorithms which are there. You can find them, one on electrolytes and other parameters there. We have got the books available there. The protocol and the basic pediatric endocrinology is specially meant for pediatricians and postgraduate trainees, and the advanced pediatric endocrinology for the advanced course advanced people who want to do pediatric endocrine further evaluation. I'd like to thank all the chairpersons that we have here, including we have got Dr. Pradeep from AIIMS Patna, Dr. Nitin from Lucknow, Dr. Jyoti from Nepal, and Dr. Tarun from Regency. And I'll request Dr. Alapan to give the mementos to individually to that. To Dr. Jyoti. To Dr. Tarun. To Dr. Nitin. And I think with that, we are coming to an end of this program, and we'll be closing our live stream in that regards. Before that, I'd like to thank all the faculty members who have come from across the country for the last 5 days. We had so many faculty members. Even now we have Dr. Vijay, Dr. Mahesh, Dr. Arpita, Dr. Ayesha. So many people were there. They are still there. All the participants from across the country and even international participants will be there. The Regency team, Dr. Atul and Dr. Rashmi Kapoor, Dr. Rishi, Dr. Chaurasia, who was there, our patron, all the sponsors who are part, which are essential for this team. Our CDR team, we have got Vibha, who is now a consultant with us, Dr. Dhwani, Dr. Alapan, Dr. Sandeep, Prashantji, Nikhil, Hariom, Aditya, all of them were really involved. Ravidatji and Durgesh who were there, who were involved from there. Umesh from Team IAP, all the sponsorship and all the local staff were involved in that. So we'd like to thank all of them for this wonderful conference. We have had a 5-day marathon session. And I